Keep us on agenda. We are honored today. We're going to be talking today about mental health, substance abuse, and incarceration. And first up, we have to speak to us is Wendy Bailey, who's the Executive Director at the Mississippi Department of Mental Health and has been a great partner to this legislature. We are pleased to have her today. Thank you. That is not yours. Yeah. Let's see if we can get hers pulled up. She loves to be behind the scenes. Is that on? Okay.
Thank you. That's mine. Yes, sir. Thank you. Okay, so for us to get started on this first slide, I know many of you have seen before, but I always like to start with this. And since we're going to be talking today about women, children, and families and mental health and substance abuse, I want you to kind of see what the state system is and how it is set up, because many of the services and supports that we're going to discuss today, of course, fall within this system. So the first part is state-operated programs and community services, and we will go through some of those. Those are the ones that are directly operated by the Mississippi Department of Mental Health. And then you have regional community mental health centers, which are not operated by DMH, but we do certify, and they're part of county government, and they are your main community mental health center service providers in Mississippi. And then other nonprofit and for-profit service agencies and organizations that the Department of Mental Health certifies. Currently, we certify about 125 providers across the state, and that does include those 11 community mental health centers as well. Okay, so to kind of give you an idea of how that structure is across the nation as well. So we're here to talk about women, children, and families, substance use, and mental health. So Mississippi here is colored yellow in this map, and that is because there's 12 states, including us, where all three, mental health, substance use, and intellectual and developmental disabilities, fall under one agency. And that is the way it's set up here in Mississippi. So you can see for mental health, there's a responsibility for adults, children, and youth. For substance use, there's prevention and treatment. And then, of course, for intellectual and developmental disabilities, it's adults and children as well. So state operated. These are the services that the Department of Mental Health directly operates related to children and youth services. We have Mississippi State Hospital that's located in Rankin County that many of you have toured before. And yes, Senator Kirby, thumbs up. Mississippi State Hospital has a child and adolescent unit. They have 16 beds, and they mainly serve adolescents because it's extremely difficult to staff the child side. But we do take children ages 5 to 17 to 18. But there's 16 beds, and in FY24, they served 143 children and adolescents at Oak Circle Center. Those children come to us through a court commitment. And then we also operate the Specialized Treatment Facility. That is in Gulfport, and it is a PRTF, or a Psychiatric Residential Treatment Facility. It is for adolescents aged 12 and up. And again, this is also court commitments that come to us. It's in statute. That is the only psychiatric residential treatment facility that the state operates. The rest are private providers, and we do not license or certify PRTFs. That is through the Department of Health. So STF has 32 active beds, and they served 96 youth in FY24. You may wonder, with 32 beds, why only 96 were served. The average length of stay at STF is about 6 months. It's a step down from an acute psych unit. And many times, I think even yesterday, you probably heard this from Commissioner Sanders. You have some children who've been at an acute psych unit, like what is Oak Circle Center at State Hospital, and there is no level of care between acute psych and between a PRTF. And sometimes kids aren't necessarily ready for a PRTF, but that is the step down in Mississippi. So the average length of stay is around 5 to 6 months at STF. Yes.
So one question in this, they're very rare. I know beds are difficult here. What's your occupancy rate like in these beds? It's pretty full.
They're always full. STF is always full. And I will tell you that is pretty much, I mean, sometimes you might have a milieu because it's males and females. So you might have more males and there may have to be 1 or 2 beds pulled offline. Also during COVID, of course, that was, a lot, but there's 32 right now, 32 filled beds at STF today. I'll also tell you that the waiting list for STF is about 42 days. It's about 42 days because many times the children and adolescents that we serve at STF either have been denied at a private provider or they have more difficult and complex needs than a private provider may be able to do, and they come to us. Again, it's court commitments too.
Can I ask a question on this too? How many of these, do we have any stats on how much of this is related to addiction and drug use or anything like that? Do we have any stats on that?
We do. And I'm actually going to talk a little bit on another slide about what both of those state-operated programs provide for substance use treatment. I will say there are more beds at STF. That is the ones that are currently staffed. There's 32 active beds. We can have 48. They are not staffed. So I don't want to mislead anybody. They're 32 active beds. The regional community mental health centers, again, these are part of county government, and there are 11 in the state. You can see how those are broken down on the map. They are the primary service providers of outpatient community-based programs, and they provide residential treatment for substance use and crisis stabilization that are both kind of inpatient. And we'll talk some more about those as well. DMH is responsible for certifying, monitoring, and assisting the community mental health centers. And we'll hear about some more of the services that are provided to the populations we're talking about today. There are core services for children and youth that have to be provided when someone's certified as a community mental health center. And we'll go over those as well. In FY24, according to the data that comes from our data warehouse, which is a requirement for the community mental health centers to enter that client level data, and it's also sent to the federal government. There were about 72,800 people unduplicated that were served across the state by the community mental health centers, and about 23,000 of those were under the age of 18, just to give you an idea for children. DMH certified providers. So I mentioned there's about 124, 125 certified providers through the department. 11 of those are the community mental health centers. Out of that number, there's 46 providers that are certified for children and youth services. And 34 of those 46 provide all the core services. And you can see those listed: outpatient therapy, community support services, psychiatric physician services, crisis response, pre-evaluation screenings, because pre-evals are also done for adolescents, not just adults, for a court commitment, peer support services, and day treatment. And I know you have Melody on the agenda, Dr. Medeiros, in just a little while as well, so she can go into some more detail about that. Okay, so I've tried to kind of break this up today. We're going to look at substance use services and providers first for children and youth and women, and then mental health services and providers for children and youth and women. But first, I really want to drive home the point that the success of women and children and families in our state is dependent upon their overall health and social determinants of health. It's not just mental health, which is what makes study groups like this so important, is you're looking at the big picture and not just one item. This is a report from America's Health Rankings for 2023, and Mississippi's 50th and healthiest states. They looked at things like social and economic factors, physical environment, clinical care, behavioral health, and physical health problems. So as we break down and we talk about mental health and substance use for children and youth and families, it's just important to remember that their health of the citizens in our state is dependent upon their education, their access to healthy foods, their access to health care, to transportation, safe housing, economic stability. All of those things are interconnected. So substance use disorders. I wanted to provide just a few stats for you to get an idea of how we compare. The Substance Abuse and Mental Health Services Administration breaks up the United States into regions, and we're in Region 4. So you can see those states up at the top, those make up Region 4. This is a little difficult to read on the screen. Hopefully it's a little easier in your PowerPoint. But for substance use disorders, the national average for ages 12 to 18 is 7.7%. 7.7% of people aged 12 to 18 have a substance use disorder. Mississippi is 7.7 compared to 9 for nationally. So national is 9. I think I misspoke that a minute ago. Nationally is 9, Mississippi is 7.7. So we're slightly below. The regional average, which is those states for Region 4, it's 8.3 and Mississippi is 7.7. So we're slightly below national and regional for adolescents with substance use. Same way with drug use disorder. Substance use includes everything. Drug use disorder specifically, we're 6.2. You can see we're slightly below the national and regional average. Alcohol use disorder, we're 2.6, and the national average is 3.3, and the regional average is 2.9. So in all three areas for ages 12 to 18, we're slightly below our neighboring states and the national average. For adults, it's a little bit of a different story. This is aged 18 and older. It's not broken down by just women, but this is age 18 and older. The national average for substance use is 17.8, and Mississippi is 16.8. The regional average is 15.9. So we're a little bit above the regional average for substance use disorders for the state. Drug use disorders, it's about the same. Mississippi's a little bit higher on both the regional and the national average. And for alcohol use, you can see that Mississippi's 10.4 and the national average is 11.3 and the regional average is 10. And these are all percentages. So when we talk about substance use, what exactly does the state operate or fund for children and youth, for adolescents? That's what we're talking about right now, adolescents. Oak Circle Center at Mississippi State Hospital, they have 16 beds. Those are for acute, psychiatric, and they can treat substance use. You do not have to have a psychiatric disorder to be admitted to Oak Circle. It can be just substance use, but many times it's both. Many times it's a dual diagnosis, but you can be admitted to Oak Circle Center as an adolescent for substance use only. And it is males and females, 16 beds. Sunflower Landing, which I'll let Dr. Medeiros speak to this because their communal health center operates this program. It is substance use treatment for adolescents, ages 13 to 17. It is 16 beds. It's female only. That is the only substance use treatment beds for adolescents and youth that the state operates or funds. So one thing that I think needs to be looked at, especially possibly with some of the opioid settlement money, And Commissioner Sanders may have spoken about this yesterday, and possibly Judge Bevel too, because we've both had conversations about this, is the need for a secure, locked, adolescent residential treatment facility for substance use for both males and females. Judge Bevel called me about a specific situation several months ago. The child was 15, had already overdosed 6 times, was in the hospital because he was going to have a new liver, and he was in CPS custody, and he would run. And she said, we can't put him somewhere that's not a locked, secured facility. He's going to elope. We have those beds at Oak Circle Center, and that's all. So I think an investment for the state would be looking at a secure adolescent residential treatment facility. And you'll see I said regardless of an ability to pay, because so many times these adolescents, they can't afford a place that's $30,000 a month. Okay, substance use in pregnant and parenting women. This statistic is startling to me, and you've probably heard this from Dr. Edney with the health department before. But in the United States, 22.7% of all deaths that are pregnancy related are due to substance use or mental health. So all pregnant women who die during their pregnancy, 22.7% of those are due to some type of substance use or a mental illness. That could be a drug overdose, a suicide, other incidents and conditions that occur. But we also know that 1 in 5 women in the United States, and this is the same in Mississippi, have a mental health condition or a substance use disorder during their pregnancy or postpartum. This is not uncommon. Being screened and connected to treatment during pregnancy is vital for the success and the health of the mom and the child. So substance use while pregnant has severe risk. And I know we know this, but for the mother, you have increased transmission of HIV and other STIs, miscarriage, preterm labor, premature death, poor health outcomes. For the unborn child, there's low birth weight, there's withdrawal symptoms, there's fetal alcohol syndrome disorder, there's physical, behavioral, and intellectual disabilities, there's premature birth and stillborn. These are all related for substance use for a pregnant woman. Treatment centers in Mississippi prioritize admission for parents and pregnant women and IV drug users. I'm going to talk a little bit about that. If a bed is not available within 48 hours, they have to do a referral for prenatal care counseling and education. This is because of our federal block grant. So the state of Mississippi receives 2 federal block grants, a substance use block grant, which is around 14 million, and a mental health block grant, which is around 8 to 9 million now. One of the terms and conditions to receive that federal funding is that pregnant, postpartum, and parenting women are a priority population. And they are deemed a priority population because they are underserved, they're uninsured many times, or they're underinsured. This also shows you, this is the United States, but you can see Mississippi. This is illicit drug use for women ages 18 to 49. Mississippi ranks 30th for illicit drug use for women. And you can see we make up about 11.2%. Louisiana's 45th and Alabama's 47th. We're kind of in the middle for illicit drug use. So we talked about the 22% of pregnancy deaths related to mental health and substance use. 11.4% of all pregnancy-related deaths are due to substance use disorders. So 11.4% is substance use disorders. So why is pregnant and parenting women a priority? You can see here, this goes back to 2019 to 2023, which is the most recent data. This is actually data from the Department of Health. In 2023, so this is last year, it's the calendar year, there were 30,486 pregnant and parenting mothers in Mississippi. 857 of those were in need of substance use treatment. The way that's determined is by substances being in the infant system or the baby's system or the mother's system when the baby is born. So that is how that's determined, is there was a substance in the mother's system or the baby's system when they're born. So 857, I want you to kind of keep that number in mind because we're fixing to see how many received treatment. Oops. So this number right here, the blue, that is how many received treatment versus how many are in need of treatment. And we're going to talk about this a little more too. So the blue is how many women were reached and connected to substance use treatment in the state. And the orange is how many were in need of treatment. Oops. So knowing this is a challenge, what is Mississippi doing to try to address it? And these are just a few things that I want to highlight. Again, we prioritize admission. The providers that are included in that prioritization are the 11 community mental health centers and 4 other treatment providers that DMH certifies. There's the Alcohol Services Center in Jackson, the Center for Independent Living in Jackson, Harbor House in Jackson, and the Mississippi Drug and Alcohol Treatment Center in Biloxi. They all prioritize admissions for this population. Again, if a bed is not available within 48 hours, they have to refer that woman for prenatal care, counseling, education to be provided. So here is our statewide residential bed capacity for parents and pregnant women with dependent children. This is what the state funds. In 2022, FY 2022, there were 52 beds in the state. We made it one of our priorities at the Department of Mental Health to increase that bed capacity. You saw how many are in need. If everyone in need received treatment, and there's 52 beds. In FY 23, that was increased to 76. And in FY 24, it's been increased to 86. We need to see that bed capacity expanded. We've had a significant increase over the last few years, but we need to see that increase continue. Again, this is residential bed capacity for parents and pregnant women with dependent children. So this is a woman who has reached out and been connected with residential inpatient treatment, but has a young child and needs her child to be with her during treatment because she may not have anyone else to take care of her child. So these are providers that also allow this parenting, is what we call parenting women, the child to stay there as well. So these are the pregnant and parenting women providers in the state that make up those 86 beds we just saw. There's 3. There's 3 providers in Mississippi. You have Fairland Center, which is operated by Region 6. You have Catholic Charities Born Free, which is here in Hinds County. And you have the Mississippi Drug and Alcohol Treatment Center in Harrison County. Now, the children have to be under the age of 5 to be able to stay. That differs in some states. Some states are under 5 are under, and then there's some states that have ages 10 and under. Arkansas is 7 and under. Tennessee has 1 provider that's 10 and under, and the others are 5 and under. So it's a little bit different from states. Here in Mississippi, with those 3 providers, the dependent child has to be under the age of 5. So at these providers, what occurs? We have early intervention HIV services. We have DUI, because many times the DUI can be associated with this. We have withdrawal management and detoxification, which of course, if the woman is pregnant, has to be handled very carefully and can be done, absolutely. Medicated assisted treatment for opioid use disorders. There's outpatient treatment. There's intensive outpatient treatment, residential treatment, which again is when they're staying at the facility, and then peer recovery support services. When the woman is connected to treatment at one of those three providers, they are also connected to prenatal care. Many times these women have not had prenatal care, so they're connected to prenatal care as well. And then they're connected postpartum after the delivery of their baby as well to continued medical care. So what does the state operate and or certify and fund for substance use services for women? This is not pregnant and parenting women. This is just women in general. Mississippi State Hospital has a substance use disorder unit for women, and there's 25 beds. It is accessed through civil commitment. There's 25 beds at Mississippi State Hospital. They serve 210. Last year, the average stay is about 30 days for residential treatment. Then you can be connected to step-down treatment, sometimes transitional, and intensive outpatient at another provider when you leave Mississippi State Hospital. The average wait time to access those 25 beds is right under 6 days. There's also 20 DMH certified providers that provide services for women for substance use. That's a variety of level of care. Some may be residential, some may just be outpatient or intensive outpatient. It's a variety of different services that are available to women. Commissioner Sanders may have talked about this yesterday some, but there is an act that was passed in 2016. It's the Comprehensive Addiction and Recovery Act. And it was national, and what this requires is that OBGYNs are mandated to report to CPS, Child Protective Services, when a pregnant woman has substances in her system or when her child is born with substances in their system. So when this act was passed in 2018, the Department of Mental Health entered into an MOU with Child Protective Services to make sure that when Child Protective Services receives that referral from the OBGYN, that then they are able to connect with a treatment provider. Many times it may be a woman that they have already worked with in the past that's connected to one of their social workers, and they handle that. But also, we can refer to a treatment provider as well. Commissioner Sanders and I have had a lot of conversations about this. We need to enhance this partnership between us, CPS and DMH, but also with OBGYNs in the state to educate them on how to have this discussion with women and how to make sure that women are encouraged to seek treatment, because many times there is a fear that if she tells her doctor that she's struggling with a substance use disorder, that CPS is going to come and take her baby. And we need to clarify and make sure that the message is there that we want you to get treatment. We want you to get better for you and for your baby. So we've had some discussions on how we can kind of enhance this and do some better education across the state. And here's one of the reasons why. And we're trying to dig into this right now. So again, the OBGYN notifies CPS. CPS gets the referral that the woman is in need of treatment or has substances in her system, or the baby has substances in its system. They received 272 referrals from the healthcare sector in 2023, a very big drop from the previous year. And we know substance use disorders are on the rise. So there's some breakdown with the referrals. And then you can also see on this next slide, this is how many were admitted into treatment. So in 2023, there were 272 that were received by CPS. 95 of those were sent to DMH providers, and 18 were admitted into treatment. So I'm sharing with you today this because this is going to be a priority with CPS and us to figure out what is going on here. and to address where the problems are and to make sure the education and the awareness and the referrals are coming in to get these women into treatment. Okay, to move into that substance use, to move into mental illness and serious emotional disturbances for women and children and families. 50% of all mental health conditions are established by the age of 14. 50% are established by the age of 14. 75% are established by the age of 24. I think many of you have heard me say this statistic before. It is an average of 8 to 10 years from the first onset of the symptom to the time people receive treatment, many times. We're losing that many years in between for early intervention to occur. Screenings and early intervention are vital for the future of our children. We have to address both of these. If you make screenings a priority, but you don't have access to treatment, you've done half the puzzle. If you have access to treatment, but you're not having screenings occur, again, you've done half the puzzle. They go hand in hand. You have to have screenings and you have to have early intervention. I want to bring this up briefly because this is just a national task force that's going on that just folds so nicely into the work that you all are doing here as well. Congress created a task force for maternal mental health. And they're doing this through SAMHSA, the Substance Abuse and Mental Health Services Administration Advisory Committee for Women. One of the main issues that they've discussed during this maternal mental health task force is that untreated conditions, again, they're not being screened, there's no early intervention, people aren't connected to treatment, that untreated conditions are costing the United States over $14 billion. And they, of course, are having long-lasting negative effects, and it's affecting our children. They're also talking about gaps. The same thing that we're talking about here in Mississippi is being discussed in all states across the nation. Where are the gaps in services? One of the gaps that's consistent, no matter where you are, it seems to be, is perinatal depression. Screenings for this and connection to care and treatment providers is needed. There are 5 pillars in this national task force that we're looking at: building infrastructure, accessibility, data and research, community engagement, and lived experience. And I think these are all things that y'all have discussed in previous meetings as well. Through this national task force, they came up with 5 key priorities: that there needs to be more awareness and education, a better understanding of the public, and focusing on that early recognition and that early intervention. Access to care. Are there providers? Is there a way to access those providers? How is that in rural areas of the state, especially, again, going back to that pregnant and postpartum? Integration of services, making sure that services for maternal mental health are integrated throughout primary health care. We talk about there is no separation of physical health and mental health. It's all health care, and it needs to be integrated. Research and evidence-based practices, getting a better understanding of what are the best practices and what is evidence-based when it comes to the care of maternal mental health conditions. And then equity and inclusion, making sure that all communities have access to those. Some of the recommendations that has come out of this national task force is routine screenings, number 1, routine screenings. You can't provide treatment if you're not screened and you don't recognize that there's a need for the service. So routine screenings, early detection and intervention, training for healthcare providers. So training even for primary care on how to recognize postpartum depression. We've hosted last year a postpartum depression conference in 2023, and then we had a suicide prevention conference last month and had one of our keynotes was on postpartum depression and suicide, making sure that that is interconnected and that our healthcare providers are trained. Community support networks, What you have available in your community through nonprofits and support groups and advocacy groups is so important to that woman and to those children. So making sure that they have access to that, but also that they know how to navigate the system, because the system can be very confusing. Utilization of technology, that is something we've learned since COVID. Telemedicine and utilizing technology, especially in areas where we're struggling with providers. And then Policy Academy. They're encouraging states to develop policy academies and having study groups just like you're doing on how to address this issue. The health department is also doing excellent work in this area. So we talked about substance use with pregnant and parenting women, and I want to talk a little about postpartum depression. So postpartum depression is common among new mothers. We've talked about how the community mental health centers are the primary providers of outpatient mental health services in the state, and they receive referrals from OBGYNs, from physicians, from CPS, from pediatricians, and they can provide treatment. They have outpatient therapy, they have crisis stabilization, and they can provide and connect that individual to treatment. We do need, though, to enhance awareness and screenings for postpartum depression. We need to do that in the healthcare community and make sure that there's an open conversation about it. There's a lot of confusion about the baby blues and postpartum depression. And the baby blues can last for a few days to a few weeks. Postpartum depression can happen months after the birth of the baby and can be debilitating. And the mother needs treatment, and they don't need someone to tell them, oh, it's just the baby blues, it's going to go away. So there needs to be more education and awareness about what postpartum depression is. There's 600,000 women affected by postpartum depression every year. 1 in 7 of all new mothers experience postpartum depression. 20% of those women experience suicidal thoughts. And suicide is the second leading cause of death for postpartum women. We also know that 40% of women who experience depression after childbirth showed signs during their pregnancy. It just wasn't caught and treatment was not connected. So postpartum depression, obviously it affects women, and then we want to move towards their sweet babies and school-based services and what we're doing for our children and youth in our state in the area of mental health. So with school-based services, there are 519 school-based therapists at schools around the state. Some of you also serve on the pre-K and post-secondary task force, and you've probably heard me present some of these slides. But with school-based services, there's 519 school-based therapists according to our records. 325 of those are with community mental health centers, and 194 are with private providers. CMHCs are required to offer their services to schools, but the schools are not required to accept the services, but they are required to offer the services. And as part of our standards, if a school does not want to accept services through the community mental health center, they have to document that, and that's placed in the files with the community mental health center. Some schools decide to go with a different provider or a private provider. Those are the services that are provided. You can see there's intakes, there's outpatient, there's crisis services. It's a wide range. With our community mental health centers, they have reported some significant barriers to providing school-based services. Those include not having enough space or an office at the school, having limited time with the students due to, academics and extracurricular activities and things that are going on. Lack of phone and internet, that sometimes goes back to there's not a designated space for the school-based therapist. Privacy issues and staff shortages. And just put staff shortages in every slide, staff shortages. I will say this goes back to what I mentioned earlier. Statewide screenings and more school-based therapists are needed, because I think the Department of Education and the task force made the comment there's about 800 to 900 schools, and there's 519 school-based therapists. So many times a therapist may be split over a school district or multiple schools in providing those services. Another school-based service is day treatment. Day treatment is available at schools. It's offered by the community mental health centers and other providers as well. There's 120 school-based programs and 129 center-based programs across the state. School-based are, of course, located in the school setting. And you can see that 8 of the community mental health centers provide day treatment programs, and then there's 16 private providers. Day treatment programs must operate at a minimum of 2 hours per day, 2 times a week. So that's the minimum, 2 hours per day, 2 times a week. And then each child must receive services a minimum of 4 hours a week. Day treatment many times is used, it's of course a higher, more intense service in order to many times prevent some type of out-of-home placement. Navigate. Mississippi was one of the first states to use part of our set-aside dollars from our federal block grant to create a first episode psychosis program. And what this is for adolescents and young adults ages 15 to 30 who have experienced their first episode of psychosis. And Navigate is a team of people at the Community Mental Health Center. You can see there's 8 CMHC providers that have Navigate teams that wrap those services around that individual who's experienced their first episode of psychosis. It includes medication management, employment, sometimes GED work to get the child to have their GED. It includes individual and group therapy, education, and work with the family as well. This quote is from one of the Navigate participants, and he says, "As the program went along, I was able to learn about my mental health, receive feedback. I had a great counselor and therapist in medicine at no cost. With these great tools, I'm now able to recognize things that trigger my condition. In just 7 months, I've seen more progress with my mental health than I've seen in my entire life." Navigate is a phenomenal program, and we have room for it to grow. It's funded through our federal block grant and federal ARPA dollars. There's the number served. We have room and the ability to serve more adolescents and young adults with our Navigate program. We need to get those referrals in, because you can see that 95% of the people who were served avoid hospitalization. And again, this is somebody who's had their first episode of psychosis. So it's very effective in avoiding a hospitalization, is to have this team approach for these individuals. Intensive community support services. This is CSS, or community support services, is case management, pretty much case management. Intensive community support services allows that individual to be seen more often during the week. There's a lower client to staff ratio, and they can be seen multiple times during the week, and it provides those interventions to keep that person in the community or keep that child or youth. It's also, with children and youth, we're using it for people or children and adolescents who are discharged from inpatient care. So they've been in an inpatient facility, they're returning back to their community and connecting them and getting them ICSS services. These are provided by the community mental health centers. There's a mistake on this slide. It says DMH funds 35 ICSS positions. We do, but that's adults. In addition to that, we fund 11 for children and adolescents. There's 1 funded ICSS, intensive community support specialist, at each community mental health center. So that's in addition to the 35. The 35 are adults. There were 227 children and youth served in FY24. This was just started with ARPA dollars. So this is pretty new. And several of the positions were just hired in FY24. So we're expecting to see that number increase next year. You can see in 23, which was the very first year, it was 154. So it's a program that's growing. Wraparound facilitation. This is a family and a youth-guided care coordination process. There are 11 providers that are certified by DMH to provide wraparound facilitation. And again, it wraps the services around the child. It's a partnership with DMH, the providers, the Division of Medicaid, and the University of Southern Mississippi. There were 1,427 kids served with wraparound facilitation, and 1% needed a higher level of care last year. They were able to avoid a higher level of care with the service. Making a Plan teams, these are local multidisciplinary teams that are in the community. There's 55 across the state, and they serve children and youth between the ages of birth to 21. And the purpose of this is many times it's kids that are at risk for an out-of-home placement or maybe at risk of a hospitalization, and it's how to get them connected to the services and supports that they need. The multidisciplinary team has DMH, it has private providers, mental health providers, CPS, youth court judges, school districts. They can all refer cases, and they're all part of the team in many cases. You can see that there were 978 children and youth served in FY24, and that was an increase by 22%. And these are referrals that come. So we've seen an increase in the referrals to the MAP teams just over the last 2 years. Juvenile outreach programs. These are, again, provided by your community mental health centers and funded through the state. There's 12 juvenile outreach programs across the state. And these programs provide linkage and access to mental health care when someone's leaving the juvenile justice system. It's a warm handoff. The process is started while they're still in the detention center, and then they're connected to the care after they leave the detention center. You can see here, it's assessments, it's community support, crisis intervention. There were 2,284 Mississippi youth served just last year with the juvenile outreach programs. Of those, 70% were referred to their local community mental health centers and continued treatment. That's how many continue treatment after they left. And of that, 15% were re-involved with the justice system. That's one thing that we look at. That's an outcome. Are they connected with the care? Do they continue the care? And do they re-enter the juvenile justice system? Supported employment. As we talked about in the beginning, all of this is interconnected, and employment is key. And there's many times for youth that we don't focus on that population for employment. And we wrote an application to SAMHSA, and Mississippi was one of 7 states that were selected to be a part of this National Policy Academy. And as a result of that, we had NAMI, Child Protective Services, Human Services, Department of Education, Department of Rehab Services, and Department of Employment Security that made up our team that went to Washington to be a part of the Policy Academy, and that's continued over the last 12 months for virtual meetings as well. I named off all those agencies because you can't do it alone. You have to have those partners. You got to have everybody at the table. But the great thing about this is the Policy Academy, which is to connect young adults, 16 to 24, to employment and make sure they have the services that they need to support them for their mental illness. As a result of that, we were able to write a TTI grant because of this work, and we're starting pilots at 3 community mental health centers to have a full support employment program. So we'll be starting that up very soon. I want to real briefly just touch on the crisis continuum of care in Mississippi because this impacts women, children, and families. So this is the crisis continuum that SAMHSA nationally says that a state needs in order to have effective crisis system. So first you need someone to talk to. And in our state, that's 988. And I'm going to talk a little bit about that. Someone to respond, which are mobile crisis response teams and crisis intervention teams, because a lot of times calling 988 and having someone to talk to, you still need someone to come out and physically respond. And then sometimes after that response, you may need somewhere to go. And we have diversion centers and peer respites that are pilots starting up in the state. That's very new. There's crisis stabilization units, which we'll talk about in just a second, and acute psychiatric hospitals. There's also PRTFs, as we mentioned, the psychiatric residential treatment facilities, and then the state operates one of those. And then after you've had somewhere to go, you need someone to follow up to me, that's the most important piece of the four, because if you've experienced a crisis, and especially if you've had to go somewhere inpatient, you need that follow-up care after. So the crisis continuum, many of you have seen this slide before. You have your person in crisis. So you're someone to talk to, 988, our crisis line. 80% of the time, those can be resolved over the phone. But then you have about 20% that have to have someone to respond. They're in a more significant crisis situation and they need a physical response. That's where the mobile crisis teams come in that are operated by the community mental health centers. About 70% of the time, it can be resolved in the field. The person can get connected to care. They can get an appointment, a change in medication. You can respond in the field. But then there are some situations where they need somewhere to go, like we just talked about, and that's where you have your crisis facilities. When you have this full continuum that is SAMHSA promotes and that we promote, you see a decreased use in jail, inpatient programs, emergency departments. You see that decreased use. It's also least costly. The more restrictive the inpatient care is, more costly. And when you have these other services, it's less costly and it's better for the patient and the client. So 988, just real briefly, 988 is a 3-digit crisis line. Congress passed legislation in 2020 for 988 to be national. It changed the National Suicide Prevention Lifeline, which was a 1-800 number, and you'd have to remember a 1-800 number when you're in a suicidal crisis. It changed that to 988, but they also changed the messaging for it to be a behavioral health crisis line, not just a suicide line. So we have 2 call centers in Mississippi that answer our calls. We are consistently, since it started in 2022, in July of 2022, we have a top 10 answer rate in the nation, which means when you call in Mississippi 988, you're going to get the 988 call center here. I think last month it was about 96% of all the calls were answered in state. The importance of that is if you have it roll over to Alabama or Georgia, they don't know Mississippi resources. So it's really important to have a high in-state call rate. Oh, let me just also say this, just so you can kind of see how it's growing over the last couple of years. So in FY23, well, in FY22, there was about 11,000 calls. In FY23, there was 13,500 calls. And last fiscal year, FY24, there were 15,500 calls. So as more people are becoming aware of 988, we're seeing the calls go up. We're seeing the numbers. I hope you've seen the billboards. They're all up and down 49. Mobile crisis response teams. So you've called 988, your crisis can't be resolved over the phone, and you need a mobile crisis response. So these are funded by the state and the services provided by the community mental health centers. They're available in all 82 counties. That's a requirement of the funding and of our standards. It is a 3-member team, and they go to where the crisis is occurring. That's the mobile part of crisis response teams. They're supposed to go where the crisis is being experienced at the moment. It's also important because they many times work in conjunction with local law enforcement with situations, and they can go into schools, hospitals. There was a situation at one community mental health center where the individual was threatening suicide and was at a railroad track. And the mobile crisis team went and located the individual and saved their life that day. They were about to attempt suicide. So they go where the crisis is occurring. One thing, and I think this was mentioned by Commissioner Sanders yesterday, is she has expressed a need with me and others about children being served with the mobile crisis team. And they do serve children. They serve adults, children, mental health, substance use, and IDD. Our standards say they're supposed to respond to all of those groups. But there are growing significant and complex needs with the children in our state. So one of the requests that we've made is a child and youth specialist position be added to the mobile crisis team, because it's only a team of 3 right now, adding a 4th member for children and youth specialist. There were it's about 7,700 calls to the mobile crisis teams because more people are using 988 for the phone call now. And 988 can dispatch out a mobile crisis team. There were 2,711 face-to-face responses last year. So for crisis stabilization, sometimes again, you may need somewhere to go. And in our state, there's 15 crisis stabilization units. That's including one for children. So there's 204 beds across the state for adults. And then Region 9, there, Jackson, Hinds County, they operate a 12-bed child and adolescent crisis stabilization unit. They served right at about 152 kids last year in their CSU. Dr. Medeiros, who's speaking after I am, we have provided her a grant and she is working hard to get an 8-bed crisis stabilization unit for children and youth in North Mississippi. The legislature actually provided funding. We had the one in Central Mississippi, and they provided funding last year for one in North and one in South. We put out an RFP for South, but we did not get any submissions for a provider. So we're working on that North one right now. The CSUs for adults, they serve 3,880. I don't have that breakdown with male or female, and I know we're focusing on women here, and I can get that for you. But 93% of the time, the individual is able to be diverted from a state hospital. This is a key service provided by the community mental health centers. It accepts voluntary and involuntary admissions, and the purpose is diversion and quick access. You see the 204 beds, the maximum is 16 beds. Can't have more than 16 beds because of a federal regulation called the IMD exclusion. So you cannot have more than 16 beds. Trauma-informed approach to care. I really wanted to touch on this, especially with children and youth, but this is for adults too. A trauma-informed approach to care is, in simple terms, you change your thinking from what is wrong with you to what happened to you. Because there's some trauma, many times that's occurred in someone's life that has led or enhanced their mental illness or their situation. So it's looking through a trauma lens and understanding the impact of trauma. This is especially with the children in CPS custody. TFCBT is trauma-focused cognitive behavioral therapy. And this is something that we need to look at expanding in the state as well. We've set an internal goal that all of the staff, doesn't matter if you're providing patient care, all of the staff at our specialized treatment facility, the only PRTF that we operate, will be trained in TFCBT in 2025. Many of them have already been trained, but it is our goal that everyone is trained. This is something that needs to be looked at for all of the PRTFs, is that they do have trauma training. Trainings to increase awareness. So I'm just going to go real quickly through these. There's Shatter the Silence, which is a suicide prevention program that we have. There were about 9,000 people trained last year. We can go into the schools. We do 45 to an hour presentations, and it's about suicide prevention. We also have this for public safety, for older adults, for faith-based, but here I focused only on the children and youth aspect in the schools. It's very important that schools are aware of suicide prevention warning signs and that kids know what to do when their friend tells them that they're having thoughts of suicide. Stand Up Mississippi is a campaign that's against the opioid crisis. You can see all the partners that are part of that across other state agencies. The purpose is to put an end to the opioid crisis in our state, and we do that in several ways, or we're trying to do that in several ways. Narcan or naloxone distribution can reduce an overdose, and the legislature passed legislation this year to make that available to other groups as well, and also provided $25,000 in funding to our agency to enhance our ability to provide Narcan or naloxone. Looking at, again, expanding access to treatment for substance use, particularly pregnant and parenting women, and outreach. This is a site, it's called Stand Up MS, and you can go to this site and you can look at the resources for substance use treatment. You can find out how to get naloxone, Narcan. You can find prevention steps and other resources. It's solely on substance use. Mental health first aid is another training. There's mental health first aid for youth, which we currently have a federal grant and can offer this at no cost to schools. And it's an important training for our educators to have to be able to recognize those warning signs and how to talk to children and how to connect them with help. House Bill 231 was some fentanyl and drug education that was passed. This is just now getting up and started. There's 2 curriculums that has been selected, and there's pilots in several of the schools across the state. And it's to increase their awareness of fentanyl and the dangers of fentanyl and substance use. Back in July, we were looking at ways, or we have been in the last couple of years, on how to increase the knowledge of the resources that are available and make it easier for people to navigate the system. Because many times when you're in a mental health crisis, it's especially difficult to navigate the system. So we had a mental health website. It was called mentalhealthms.com, and we transferred that over to an app. So there's an app now called Mental Health Mississippi. I hope you've all downloaded it. If not, please do. It's at no cost, and that is what it looks like. And you can see there's a resource directory, there's an interactive map. So you can go to Find Services, which is the magnifying glass, and it will pull up the counties. And then you click on the county and it tells you the providers in your county. There's also free screenings. It links you to Mental Health America, and you can take free mental health screenings to see if you might need to get connected to help. There's also crisis services, which will link you directly to your mobile crisis team, R988. So one of the main things is we know the services and supports that are available. We know the areas where we need to focus on adding more supports and services. But then we need to make sure that the public knows how to connect with them as well. So 988 is available. You have your helpline, your local community mental health centers. You can see 2 websites there that we operate. There was legislation passed for the Attorney General's office to create this mama.ms.gov website. And again, it connects mothers to all types of services, not just mental health services, but mental health does have a section on that page. And then, of course, the Mental Health Mississippi app. And then there's also a national hotline, which is the Maternal Mental Health Hotline. And that can connect individuals or mothers to care as well. And then I know I mentioned a lot of different state agencies and partners throughout that presentation, and that's because you can't do it alone. And Henry Ford is one of my favorite quotes. I found out this morning my 13-year-old son doesn't even know who Henry Ford is, and he also asked if cars were invented before I was born or after. So I said, really, that's how the Henry Ford conversation came up. I said, do you not know when a first car was invented and who Henry Ford is? And he goes, who's Henry Ford? Like, oh, what are you learning in school? So this is one of my favorite quotes. Coming together is the beginning, keeping together is progress, and working together is success. So all of these services and supports are not done alone. They are done by many providers and many partners across the state.
I want to thank you before I start too. You are truly, I've said this before, but you are truly the person who is the quickest to pick up the phone at 6 o'clock on a Friday night or 9 o'clock when there's a crisis out there to help us try to find a bed for a family or do something like that. You are always on call, and it is much appreciated. I also want to make a comment too, hearing yesterday's testimony and today's testimony. When we did these hearings 2 years ago, state agencies, and you didn't testify before, were much more in silos. This is completely different than what we hear now. The collaboration of everybody working together has been a marked improvement. And so I want to thank all of y'all for really doing that. And on that note, Commissioner Sanders mentioned yesterday that it might be a good idea at some point to have some legislation or something that allows y'all the ability to go in and look at what you license versus what somebody else licensed, so that we can streamline some processes, because there is so much overlap between your agencies. and making it more consumer friendly too, to not have so much duplication, or not duplication, but just have so many agencies involved when you have to license a facility. Is that something you would be, that you would like us to do as well?
That is something that Commissioner Sanders and Dr. Edney and I have talked about, because the Department of Health has the responsibility for licensure, but then we certify many programs, but there's a lot of programs that he licensed that we don't certify. So I think looking at just the entire licensing structure in the state could be beneficial.
Okay. Workforce issues, it is a continuous theme, no matter what hearings we have across the state, particularly in regards to any type of healthcare issue. it- and one of the things that's consistently brought out, we have some of the lowest Medicaid reimbursement rates in the country, and we also have the lowest private insurance reimbursement rates in the country. Can you tell us how this affects your workforce?
It affects the number of providers that we have in the state, and it affects our workforce as well. For example, we started the residency program at Mississippi State Hospital for psychiatrists because there is a dire need for psychiatrists in the state. And child and adolescent psychiatrists, it's even more so. And that's because many times they graduate and they leave and they don't stay in Mississippi. So having more providers is very key and important. And yes, that does play into what are the rates and what are the access to the services.
Okay. We know that we have an opioid settlement. We're going to have funds that are going to be dedicated, that we have to spend in particular areas. A lot of that funding could be directed to your highest needs. I know you mentioned a secure adolescent facility as being a top priority, some residential bed capacity when it comes to mothers that are addicted. Can you give us back a list of y'all's priorities? And I won't put you on the spot today because of what y'all's priorities are that you think that opioid settlement money should be used for in regards to substance abuse issues.
Absolutely.
So I think we would love to see that, particularly in regards to women who have addiction issues that are pregnant, and youth as well. One of the things we've had a couple conversations before, and we had that last week in JLBO, is we are aware that there are some programs that we're paying pure state dollars for that we could be getting possibly some Medicaid reimbursement. Are you aware of programs in your agency that we might be able to get a Medicaid reimbursement for?
Yes, there are some. For example, one that I talked about today, residential treatment. Substance use residential treatment. That 16-bed IMD exclusion rule applies to substance use treatment as well. But there are waivers. There are waivers that the state can apply for in demonstration projects that the state could apply for. That could help our residential treatment facilities with funding. And then there's others as well. So supported employment, for example, is one. We're funding that through the state. I know at one point there was a waiver or a demonstration that you could apply for. There's some around mobile crisis and other services as well. There's one state, Colorado, and they just submitted, and it's been approved, in just the last few months, through CMS, a demonstration for the IMD exclusion for their acute psychiatric. So if they keep their average length of stay under 30 days, you can have more than those 16 beds that IMD exclusion is waived, and they will provide up to 60 days of treatment cost reimbursement. So there's some different things like that.
Okay. Is there anything particular that we're missing on as regard to women with addiction issues and stuff like that? Because we know that over 70% of our children are born to mothers who are served by Medicaid. So are there some particular things that we could do more in regards to that to get those federal match dollars?
Yes. I'm not a Medicaid expert at all, but I do know that there's some states that have been exploring that. And again, that residential treatment, which would be for pregnant and parenting women too, having that ability.
Okay. one of the things that came up in a meeting you were in a couple of weeks ago that several of us were in is there, we're all kind of working still though, looking at these silos or anything. Is there any state plan that is being worked on or that we have that's operational between agencies? For instance, that the Department of Mental Health, in regards to, let's just say, maternal issues, is there any state plan that we know, like the health department works on and the y'all are working on, and CPS and looking at that, Department of DHS, and then Medicaid, who has our MCOs or anything like that? Is there any state plan that y'all are all collectively working on that measures these outcomes and is looking at the things we need to do to move the metrics and make this a better state?
That is getting better. And you, as you mentioned, the silos are breaking down. And I know us as agency heads and our staff are working together. The health department has the state's health plan. And there's components in the health department state health plan that are related to mental health. And that are related to maternal mental health. And then I know we have it in our strategic plan and other agencies has it in theirs. But if you're looking at one plan that incorporates it all, I would say the closest to that would be the health department's plan.
But there's nothing like that y'all all come to the table and sign off on that says, these are the things we're
No.
going to do to move these numbers and metrics?
No.
Okay. All right. Additional questions? Senator Hill?
First of all, on the reimbursement rates that were discussed on Medicaid and insurance, and then second of all, on the waivers that you discussed. So if you'll address the waivers first, who is it exactly that has to apply for these particular waivers? Is it the Department of Medicaid? Is it something the governor can send a letter to Medicaid for? Or what would be the mechanism to make that happen?
They are applied through the Division of Medicaid to CMS. And so it would be something that I would absolutely, Mr. Snyder needs to speak to because I'm not a Medicaid expert, but it goes through Medicaid to CMS, the demonstrations and the waiver applications.
Okay, and on the reimbursement rates for insurance and for Medicaid, why do you think it is that Mississippi has the lowest reimbursement rates?
I can't. I think Senator Bryan wants to take my question.
And I'm not talking about Medicaid expansion, okay? You can have higher reimbursement rates for insurance and Medicaid without expansion, okay? So I'm asking Wendy, is it something that the legislature can do? As far as insurance reimbursement rates, is it something that the commissioner's office has to do as far as reimbursement rates? Now, I know when we do our Medicaid technical bill, we actually put in levels of reimbursement on certain things, which we pay for more services than we're required to pay for, okay? But if we want to recruit more doctors to take Medicaid, then the reimbursement rate is going to have to be better for the doctor or for the provider. So we got 9 senators sitting around this table, if I counted correctly. So if it's something that the legislature can do as far as saying, if you're reimbursing this much in Louisiana, you're going to reimburse that much in Mississippi. If you're reimbursing this much in Alabama, you're going to reimburse this much in Mississippi. So my question is, what is it going to take to make them do it? And if we have the authority sitting here as a body that they sent us up here to make decisions, why aren't we doing it?
I know some work's being done. One of the first steps is rate studies, is to study what are the rates. I mean, what are the rates in these other states and how does it compare to Mississippi? There's a rate study that's been done with intellectual and developmental disabilities that the Division of Medicaid did. And just last year, those rates increased and there's some more that's about to increase. And it's been a significant help to the providers because our rates were so low. So having rate studies where you see how you do compare and what is needed is that first step to be able to truly address it. You've got to know where you need to go.
Senator Brown, I think you might have had a question.
This legislature for decades has been obsessed with holding down the cost of the Medicaid budget. I go to meetings with people from other states and tell them we've got this 75% match or thereabouts, and that we're obsessed with holding down the cost of Medicaid. And literally, the response is uncontrolled laughter. States that have a 50% match think they have discovered the goose that laid the golden egg. The default setting should be for Medicaid payments, how much can we possibly pay you for this service? How much can we legally get away with paying you? And then see if there's any reason not to pay that amount. One of the reasons we have shortages of healthcare providers in Mississippi is you can go to some other state and get better compensation for what we're doing. The other thing that Medicaid does, which I didn't really realize until somebody pointed it out to me, is, and nursing homes is the easiest example to understand. If you live in Ashland, Mississippi, and your parent is in a situation where your parent needs to go to a nursing home, it means the world to you, and the real life consequences for you and your parent and all of it, for your parent to be in a nursing home there in the town where you live. You can stop by and see them during the lunch hour, in and out all the time. It's different. But if you live in Ashland, Mississippi, right now, and you're got all the money in the world, you can send mama to the nursing home in Ashland. Because of Medicaid. Because most of the people in that nursing home are getting reimbursed by Medicaid. So the fact that Medicaid reimbursement exists allows services to be available for people who are not on Medicaid. And as I say, if you, apart from Medicaid, if you're in Ashland and you've got all the money in the world, unless you want to open up a nursing home, particularly for mama, there ain't gonna be one. And that's true with services other than Medicaid and services places of that different than Ashland. Ashland's just been on mine because I've been thinking about Senator Rennick. But I mean, that's the answer is we could increase reimbursement tomorrow, but we're obsessed and proud and brag about how we're not spending any money and holding on. Ain't got no roads, but we're
Let me follow up on
no
that
water, ain't
as
got no
well.
sewer, and issued no bond.
Part of what you're saying, I agree with.
Oh, good. Let's go with
But
that.
there's
Let's run with
also
it.
a part of it to where I think that we need to look at what are we providing that we don't have to provide as far as Medicaid services? And look if that money can be redirected into some of the more higher tier.
Well, what are the services you'd like to eliminate that Medicaid's providing?
Is the higher tier things that are needed the most in the state.
Or what
that we
are
could
some of those
potentially-
things that Medicaid's paying for that you'd like to get rid of?
Okay, look, I'm gonna let you finish, then I'm gonna take Senator Hickman's question.
Anyway, looking at the things that we do pay for and how we could rearrange some of that. And I'm not just concerned about Medicaid, I'm concerned about insurance rates, okay? And if it costs $2 or $3 or $10 a month more for insurance premiums for state employers or whatever, we want the doctors here so that we can actually get treated for some of these issues that we have. And that is ridiculous that we have doctors that go to school and spend money and time getting certified, and then we have to beg Medicaid to pay them and beg Medicaid to pay them the rate that they deserve to be paid, that somebody in another state's being paid. That's my concern. And I think we can prioritize where our Medicaid dollars are being spent instead of looking at what lobbyists wants what spent on what.
Okay. Senator Hickman.
Thank you, Madam Chair. Thank you for being here. Thank you for this presentation. I just have a couple of the areas that I have questions. One, I think you said that there was more capacity for the Navigate program. You guys just need referrals. My first question is, where are the referrals coming from? then how are we marketing this program? And then finally, there are a couple of regions that don't do it. Why aren't those regions involved?
So that's a very good question. So we started Navigate as a pilot, and then we got some additional funds through ARPA from our federal block grant funds, and then some state as well to expand those. So we're just now up to 8. So with additional funding, we can expand. But the Navigate programs are marketed, the school districts, the community mental health centers, talk to the school districts about it, and the pediatricians and the physicians. We can do more on marketing as well. Again, it's a niche. It's a certain part of the population. It's 15 to 30 first episode psychosis, and it has to be first episode psychosis. That's the only group that the teams work with. But it's marketed through those groups. There's brochures that are distributed out. We have a page on our website, but there can be more. As you can see from the number served, we can increase that.
And I ask because I think it's a great program. I like what it's doing. I just want to make sure that
People know.
the key people who need to know actually
Mhm.
know. My next program I wanted to ask about was the mental health first aid for youth. How is that marketed? Who does this train? Like, how are these trainings done? Like, are you guys going out? Is it virtual? What's happening? How does that work? And how do people get involved and get that training?
So we send information to all the school districts. Every year, we notify all the school districts that it's offered and it's at no cost. We do a lot of them during the summer when the teachers are not in school because it's an evidence-based practice. You can only have up to 30 in a class because it's very interactive and you do group work too. And then it is 8 hours. So it is a full day. Mental health first aid is not just an hour training, it's 8 hours. So we do that through the school districts and notifying them. That's how the grant that we received is kind of specifically for parents and teachers and educators. And that's the main target that we're marketing with that.
So do they come to you guys or do you guys go to
We go
school
to
districts?
them, and the community mental health centers do it as well. They have trainers in mental health first aid, so it's not just us. And you can be trained in mental health first aid and do trainings outside of being with the Department of Mental Health or the community mental health centers.
And my final program, I had some involvement in House Bill 231 in
Yes.
2023. And you said you're getting that program is getting started. I think you said 20 or so school districts.
Yes.
How were those school districts selected? How do school districts get involved? And can you give me a little more detail about like exactly where you are in the process? What are the next steps? Has anybody been served or how many people been served through the program?
So it's starting with this school year. Over the winter and then of course this summer, we partnered with the Mississippi Public Health Institute. And the schools were selected by either they volunteered or when we reached out and sent out notifications through the Department of Education, they said they wanted to be a part. So it's kind of a mixture of both. And we started off with we've got about 22 school districts that are participating or schools that are participating. And we pulled together a group to review the curriculums. The Public Health Institute helped us do that. And those 2 curriculums were selected that were mentioned. And one of the great things about it is the companies that own those curriculums told us that we could even make modifications to make it fit our state. And it's also not an hour curriculum that the kids have to sit down. It's embedded. Sometimes they're 10 and 15-minute activities that are just done. But that's just starting up with the schools this fall.
And so are teachers like incorporating this in the lessons or
Yes.
it's kind of like that
That's right.
type of thing? Have we, the 2 final things and I'll be done. Have we looked at going into like areas where there are data that shows these are high areas where like fentanyl is or things like that? Have we made that a target? And then finally, like what does funding look like? I think the idea was we would be able to draw down federal funding to take care of these issues. And I can't remember whether it was a match or whatever, but where are we as it relates to funding? If we have a funding source, how long does that last? And then of course, my original question is, have we looked at like target areas for the program.
Yes, and I can get you a map. So when you lay the map down of where these school districts are, you will see that many of them are in the areas with the highest opioid overdoses. So I can provide you that. I've got that. As far as funding, the legislature provided $1 million for House Bill 231, which as I mentioned, we're contracting with the Public Health Institute to help us do this whole program. And then the pay for the curriculums to provide all of that to the schools. And the match, I wouldn't call it match necessarily. We have a federal grant. It's called SOAR. It's the State Opioid Response Grant. And with that, we also have funds that can be used as well. We use those for that Stand Up Mississippi campaign that I mentioned, and the Narcan, naloxone purchase and distribution, that's part of it. And then, of course, treatment is provided as well with that grant dollars. But those grant dollars can be used in conjunction to work with the schools for the curriculum.
How much was that grant? Is that a multi-year or one
It's a
time?
multi-year grant. It's $14 million, 2 years. So it's about $7 million each year in SOAR grants for 2 years. The bulk of that goes to residential treatment funding. Yes.
Kind of back to Senator Hickman's question too, though, is because we learned this kind of at our youth mental health meetings, those trainings that you also offer them to churches, to different to different groups and communities if they want to get trained. It's not just school districts. And you get a group of 30 people, is that right? You like to limit it to 30. And so it's available across our state to any community group that wants to get trained in that area. Is that correct?
That's right. There's mental health first aid for youth, and it can be done with any group that works with young adults. It's not just schools. It's just in the grant. That was one of our priority groups that we were working with. And yes, the maximum is 30. You do not want more than 30 in the or you can't, because it's an evidence-based program and you do it to Fidelity.
Okay, thanks. All right, Senator Wiggins.
Thank you. I want to go to your presentation where you talked about, and for I guess the committee, it's pages 5 and 6 of the, or I'm sorry. Yeah, pages 5 and 6 we have, but the substance use disorders for the minor age 12 and under, and then the
Yes.
adults. Okay. So which I thought was good for the minors, Mississippi, we're actually below all that.
Yes.
Okay. And which is a good sign and all that. Then as I understood it, when we get to being 18 or whatever, we tend to be either above our neighbors or the nationals. So other than, oh crap, I'm becoming an adult, what's going on? And then, or what are other states doing in that period that we may not be doing?
There's a lot of work that needs to be done with prevention. Now, the prevention work is done, though, usually at an earlier age, but you're right. In this area here with adults, we are higher than some of those surrounding states, and in a couple
But we're
places
lower as minors.
as minors. So the prevention work is helping, but with adults, yes, a lot of it is that it's also having access to that treatment. And many times when you have residential treatment for someone in substance use, when you get out, you are going to relapse. They say it takes multiple times of treatment. So especially as an adult. So that is one thing that you have, is an increased access to treatment and a need for treatment that we're seeing. And that is in other states as well.
You mean we
But
don't have those?
we do.
We
but
need an
could do
increase.
more.
We need more because you're becoming an adult, obviously, but we
Yes.
don't have enough, or they're not taking advantage of those.
That's right. Some of it's awareness, some of it's taking advantage of it. Some of it is in certain locations, there's not enough. For example, some states with their opioid settlement money, they're looking at like mobile opioid response teams. We don't have those. So there's several things I think that we could look at to try to address the adult population too.
And we're going to do that from y'all's
I hope so.
standpoint. Okay.
I would love to.
Okay.
I would
Because
love
it
to.
seems like an issue, definitely. Then my other question, you talked about preventative screenings.
Yes.
And my experience, we've been talking about the youth courts and all that. My experience certainly has been that when children are taken into youth court, that at least where I'm at, they're given a screening as a matter of course. But what I've seen in different places is the quality of who's doing the screening. And then also the follow-up, like, I think it's very informative to see what a 13-year-old has been through and on. If you're in youth court and you see this, you see the red flags. The issue is it's not acted upon. And the other issue is, and I love the professionals, but let's just say we're not getting the board certified psychologist or psychiatrist to do the screenings in the youth court system, which is the which is the system by which you can capture the early intervention in the screenings. So thoughts on that?
I can't speak directly to what's going on in the youth courts with the screenings, but I will tell you, you hit the nail on the head of it needs to be consistency and standardized in the screenings that are done, an evidence-based screening or a best practice screening.
Well,
that's
and
being
I'm sorry, let me
done.
just stop you right
Okay.
there. My guess is it's not consistent across our
Probably
youth
not.
courts. And then as we've heard here, we deal with the referee says, my guess is in our referee systems, we don't have that.
Mhm.
And so some kids may be getting it, others clearly are not, and then it's not consistent.
And that's the key. To me, it's consistent, standardized screenings, and then training of the individuals who are conducting the screenings, as you mentioned. And then screenings also can occur even before, though, involvement in a youth court system. Ideally, if you had screenings done in schools, you would capture some of these problems before there was ever even involvement with the youth court. So a key is the screening, but like you said, also when they're screened, are they then connected to the resources that they need? Does that piece happen? And that's where it's a puzzle. And you've got to have screenings and then you've got to have the resources, and you have to have both. But having the trained professionals to do that and standardized screenings is important.
So if you're czar for a day, how do we fix that?
Well, first, we've got to get all the youth court judges together, the youth court system together.
Keep
and I think-
praying.
Yep, keep praying. No, it's
But
collaboration.
They're working together. We heard that yesterday.
It is collaboration, and it's also a lot of times awareness. Do they know what others are doing? And, okay, so some of it may be that. So we speak at the Youth Court Judges Conference every year, so we can maybe tackle that this next time. Get some more
Well, I think
information.
that's because one thing I've been told through the last couple of years is whether it's a youth court referee or a youth court judge, permanent judge, is they ran or serve in that position because they actually want to help the kids. They probably could have run for chancellor or they could have run for something else, but the fact of the matter is they chose that. Because that's what they want to do. So, but it is about fixing what you're talking about. And so, so yes, we do that. So yes, if you're czar, we'll do that. Is there other things to fix that?
To me, it would start off with, because we have some amazing youth court judges they went into that field and that area for a reason. One that spoke yesterday, Judge Bevel, she's one of them. I think it's making sure they're all aware and they're knowledgeable about the screenings and how to conduct those and how to refer to services. A lot of it's going to be probably awareness and education. So that's where I would start. And that can be done at things like the youth court conferences, or just being able to go out and speak to them and have those opportunities. Starts with that education and awareness, and they have to know what resources they have available to them, and then see where are there areas in the states where there's gaps, where there's not the resources there that need to be. Because even if they screen them, they've got to get connected to the resources. So it's having an understanding really truly of where there needs to be additional resources placed, and then how to have that consistent standardized screening.
Last question. So you
Mhm.
mentioned, yes, before they get to the system in schools. So if you were czar, how would you address that?
We would have standardized screenings in all of the schools. Well, starting last month in August, I mean, to me, that's what we've got to work towards is that's where you get early intervention. Kids are in schools for about 8 to 9 hours a day.
Mhm.
And teachers recognize and see some of these warning signs, but you also, the teacher has to know what to do. And then you have to have school-based therapists that are available for those teachers to refer those kids to. The screening's just that first piece. So I would have screenings in all of the schools and a school-based therapist for every school.
Thank
I
you.
would.
Senator Bryan, I think you had one more question.
Well, I have the question I really wanted to ask in the first place before I was triggered by this reference to Medicaid spending. We had a youth court presentation yesterday, so that's on Senator Wiggett's mind and on my mind. I'm a youth court judge, and I've had a child come into the youth court, and it appears to me the child has mental health issues. What should happen next?
So the youth court judge reaches out. They have someone that they work with. Many times it is the community mental health center, and sometimes it's other private providers too. And that's when a screening usually occurs if the person's not already connected to help. Sometimes these kids are already receiving services, but if not, the youth
I've just
court
got a
judge-
child that's showed up, he's been screened, however, there are mental health issues, and he's not getting any services now. What should happen next?
That's where the judge can intervene to work with the provider to get them their services. I've gotten calls from them sometimes at 6 or 7. Mhm.
So you're saying it's the judge's responsibility to go find
No.
a place for the child?
The judge works and has connections with the providers. Most of them are aware and they know those and they make those connections. But it also is case by case situation. Is the child in CPS custody? Does the child have parents that are involved? I mean, it's all going to depend on what support system does the child have as well.
Well, I guess the question I'm making, or the question I'm trying to ask is, why wouldn't they just pick up the phone and call the community mental health centers and say, we've got a child with mental health issues?
And
You
many
take
times
it,
that's what
you
happens.
take it from there.
Many times that's what happens. I mean, the judge has a connection. They may work closely with a private provider in their area or the community mental health center. It's the provider, though, that provides the services, but the judges are aware, in most cases, or most that I'm aware of the resources.
But I'm
Mhm.
sorry, but
It's
we
okay.
all know, based on recent testimony, and all that the quality of services varies from community mental health center to community mental health center. Correct?
That is, well, the services that are provided.
Right. The
Yes.
services that are
Yes.
provided. So you can be in George County, which is having all kinds of
Mhm.
issues right now, and be a youth court referee, and there's a question. But you're in the Pine Belt and you get something good. That's a problem, is it not?
It is a problem.
And I think, sorry, I took over Senator Bryan. But what he is addressing is the issue that we face, which is, yes, they can do it, but the quality of services varies. And then, it is on the judge, but the judge is there to do it, but they're probably not getting it with the family there. And then it's the follow-up that has to happen.
It is. And it's making sure, again, it goes back to that our judges are educated of who do they connect to. And most of them are. The ones that call me, and some of them work with the community mental health center, and that's who they refer to. And then some do. They have other providers that they refer their children to, that they're working with.
I'm still at square one. I'll just say as an
Senator
aside.
Bryan, I
Sorry.
think we're going to have somebody
Okay.
from the community mental
Yeah,
health
yeah.
centers, and I think you are leading us into introducing her time-wise too, because I think she has some of these, she's ready to answer some of these
Okay,
questions.
but first of all, I want to say that I'm confident if we had anybody from George County here, they'd tell you things are fine in George County. The problems are in Jackson County.
Oh, no doubt they would say
But-
that.
but
And
the-
it would.
The point I'm
right.
trying to make is, it seems odd to me that a youth court judge is trying to find mental health treatment for a child. I thought that was sort of what the community mental health centers were supposed to do, was to provide mental health treatment, and I don't know why they don't. I mean, it seems to me that would be the default setting.
The youth court judge does have to notify, they have to notify whoever the provider is that they work with, that the child is there and is in need of the services. And then they they provide the service and the connection. So you do have to have both players there, educated and aware and knowing, if that makes sense.
Okay.
I still don't think I did a good
think-
job answering.
I think.
Dr. Medeiros.
Yeah, Dr. Medeiros is
Sorry.
ready to roll on this particular question. So, y'all stand up. I know everybody needs to stand up for a second. Dr. Medeiros, thank you so much. We are so grateful, of everything you do and your presentation. Yes, please. Yes.
Just leave it perfect. Sounds perfect. Thank you so much.
Y'all, this is Dr. Melody Medeiros. She is the Executive Director of Communicare for the Community Health Center that's located in North Central Mississippi. And you can refer back to the information that Wendy gave us to see exactly what counties that covers. And she's another one that is on call 24/7 that we greatly appreciate that you can call late at night to do this. She's also been serving in our youth mental health task force too, and has been doing some great work on that. So we appreciate you and appreciate what you're doing to try to help us look at better policy. So go ahead and start with us.
Okay, thank you so much. Thanks for having me. There was a lot of talk, during Wendy's presentation about the differences in the community mental health centers. And there is a pretty significant difference between the services that are actually provided. And a lot of that has to do with specific funding. So Region 2, where I am, we cover Calhoun, Lafayette, Marshall, Panola, Tate, and Yalobusha counties. And of those counties, about a third of the people that we serve are children. And we write off approximately $7.8 million in services every single year. So we provide about almost $8 million worth of services we never get reimbursed for. In order to continue to provide a lot of those services, we have to really rely on a whole lot of federal grants. So we have a little over $10 million in federal grants that we have written ourselves, and we're direct recipients from SAMHSA. Those grants help us provide additional services to the communities. So for instance, I know we were talking about youth court just now. We have some federal grants that allow us to put a therapist in the youth court. So when youth court happens, we have a therapist that's in the that's in the audience. And so there's an immediate connection between the judge and a community mental health center therapist. But without that federal funding that we have specifically gone after, it's almost impossible to do that because we're writing off $8 million in uncompensated care every year. So having the workforce to ensure that therapists are around, that's very difficult. So a little bit about what we do have. We offer all the core services. We have mobile crisis response. Some of the things that we do that are not what, the required services of DMH. We are a Navigate recipient, and we have some of the most amazing stories from Navigate recipients who have really gotten their life back together. We also have mental health first aid training grants. So we provide those trainings. We provide CIT training in our area. We also have a specific grant for our area for Narcan. So we ensure that law enforcement, emergency responders, families have Narcan. So we spend a ton of money on Narcan. We have a brand new grant called SBIRT. So that really is screening and brief intervention. So our goal with this grant is to canvass our area, that the OBGYNs, that the pediatricians, that the emergency departments have an understanding of a screening and brief intervention into treatment. They understand the CPT codes that they can use to bill it. So we're not asking them to do something that's not reimbursable. And then we will have a pamphlet of information for them to refer people immediately into treatment. And so this was a federal grant that just started October 1 for us. We also have a homelessness grant that has helped us provide a sober living facility for females. So when I created this PowerPoint, I wish I would have done it while Wendy was talking, because I think I would have done it completely different. But I will briefly go over this so we have time for questions. So globally, the CMHCs have some significant barriers to treatment, not just funding, just complete barriers taking away the funding. One of the barriers is truly lack of space inside the schools. Two reasons. One is the schools, a lot of the schools are older schools, and the child population has grown. They don't have space. They do their best. They want us there, but there is no space. So that is a significant problem. We have had therapists have to try and do a session in a conference room, and people are walking in to make copies because that's also where the copier is. You can't do therapy there. The other issue with schools is the inability to pull children out of certain classes, and that becomes problematic. And I don't know the answer to that, but I know that if we were able to pull kids out of some of the core classes, I really think that they would end up doing better in those core classes because they would have some of their mental health needs met. And then some of the barriers in the community is structures. We do run Sunflower Landing. It's a great facility. It's only 16 beds for females. I would love to open up a male facility with 16 beds. There is no place to put it. We canvass basically all of North Mississippi all the time. And the grant funding for the program, I think that we can find that funding. The funding issue is finding a space, paying for the renovations of an already erected building or building something new. And grant funding is limited on that. I know even with our federal grants, we have a cap on how much we can use for any kind of renovations. And to create a residential program, it's going to cost a lot of money. So that's a significant issue within the communities. And then, of course, workforce shortage. I don't have to say much about that, but workforce shortage is pretty significant. In the CMHC world, our workforce shortage is made even more prominent by a lot of the private providers. What tends to happen and what we see is that private providers move into the areas and they start providing services to the individuals who are insured. And if you only provide services to individuals who are insured, then your profit margin increases. And then they can pay the therapist and the physicians and the case managers a lot more money than what the community mental health centers can pay at an $8 million, uncompensated care. So that, it just exacerbates our workforce shortage. And then lack of family participation. I've worked for for-profit treatment and I've worked for nonprofit treatment, and there is a huge difference in terms of family participation in those two treatment programs. Families have got to be engaged, and there's so many barriers to the families becoming engaged. We have single parent families whose the parent may work 2 or 3 jobs. Asking them to come to a mental health family session, we want them there, but they just can't. And it kind of goes down to, do I work and keep my job and pay my bills, or do I come to provide, family therapy? And at the bottom line, we talk about mental health and we talk about treatment, and I'm a therapist, so we talk about therapy, and I love to provide therapy. It's why I went into the field. But therapy does not work unless the bottom piece of this triangle is met. So this hierarchy of need is important. And what I see every single day in the thousands of kids that we serve is that bottom triangle isn't met. They don't have adequate access to food. They don't have adequate access to shelter. And they absolutely don't have homeostasis. They have zero stability within their homes. And then we see behavioral health problems. We see mental health problems. And then we see people going to treatment and not getting better. We can't treat all those things that are mental health related when we don't have stability within the home. So I knew that Wendy was going to cover like all the services. So I kind of wanted to just go over a couple of stories because, we're on the field, we're working with these people. And I think that, putting a face to what's really happening in our towns and in our state is just really important. So this individual was in drug court, which is why we got involved with them. We actually have a drug court grant that allows us to have a specialized treatment team embedded in drug court. So we were able to intercept this individual. She was diagnosed with schizoaffective disorder. And if you don't know what that is, it's basically schizophrenia and depression combined, PTSD, amphetamine use disorder, and cannabis use disorder. She was a survivor of human trafficking. Her mother is who trafficked her. So her mother was using drugs while she was selling her child to men. She had 2 children, and clearly her home life wasn't right. So CPS took those children. She still hasn't gotten these children back yet. She completed treatment with us, and she went into our sober living. There are very few supportive housing options in the state. And this is where people that go to treatment and relapse, this is kind of the gap that we have. So she stayed in our sober living, which again is funded by a grant that we wrote. And she got pregnant while in sober living. I mean, you stop using one drug, you go to something else, but she got pregnant. We got her to stay in sober living until at least she had the baby, because we're not set up to have a parenting sober living. So she stayed in the sober living until she had the baby. She had the baby completely drug-free. Baby was super healthy. But she's moved into her grandmother's house. So essentially she's homeless. Her grandmother doesn't particularly want her and the baby there, but she has nowhere else to go. She has no transportation. She has to report to drug court on a weekly basis. She relies on us to transport her to and from drug court, again, through another federal grant that we've written. She tries to go on job interviews. She has a lot of facial tattoos that cost a lot of money to get rid of. And so when she goes to the job interview, she's often turned away. So her mental health care is managed. She has gone through therapy. She's on medication. She's managed, but she will not be managed for long if we can't figure out the homeostasis piece, if we can't figure out how to maintain her health and her home and ensuring that she has food and transportation. And the baby is currently still in her custody, but if she doesn't maintain stability, the baby will be taken out of her custody. This is a child that we have in school-based therapy, 10 years old, came in for behavioral issues and ADHD. Single parent home, the parent is IDD, so the parent has intellectual and developmental disabilities. So pretty significant cognitive issues. The child's supposed to take ADHD medications and mood stabilizers to help with the behavioral health symptoms. But because of the mother's IDD, those medicines very rarely get to the school. She has transportation issues, she can't drive, and so the meds don't often get to the school. She wouldn't even get meds for the child if we didn't pick them up and take them to the home and help them put them in a medicine container. So the child comes to school very dirty, same clothes for weeks, smells, of course, is bullied, and they have chronic lice. Our MAP team, which is fabulous in our area, funded a exterminator to go out and try to exterminate the house of lice, because this was a significant issue for this child. It didn't work. The child came, the mother got upset because the child had lice again, shaved the child's head. The child came to school in a hoodie, and wouldn't take the hood off, which is a significant school issue. And so they got sent to the principal's office. The school we work with called us in, and it's like, this kid won't take the hood off. Like, what are we doing here? And we found out that the mother had shaved the child's head. So through some funding that we had, we purchased different things that were school appropriate for the child. Multiple CPS reports were filed. The child was finally taken out of the mother's custody, but only stayed out of the custody for a couple of months. Mother got custody back of the child, and it was realized at about the 8-week mark that the child had never been re-enrolled in school. when we went out and the school re-engaged, they found out the child was actually bathing in cold water in a cow trough and didn't have access to food or other necessities. And so CPS took that child away, and which definitely needed to happen. But now we have a child who had a good connection with a therapist who's now been moved into a completely different county with family friends. Oops, went the wrong way. This is another school therapy thing, 8-year-old being seen by us because of tantrums directly related to a history of sexual abuse. The mother, this child was the oldest of 5 siblings. The mother truly cared deeply about her children. She wanted to be involved with her children. She wanted her children to be okay. But she had limited education, pretty much 0 job skills. She had a home that was really a shed that they quote unquote converted into a home, but it very rarely had electricity or running water. The children would go next door to the neighbor's house to bathe in warm water. The parent worked at a fast food restaurant, so their schedule was pretty, it was never very stable. And so she had a hard time coming in to do any type of parenting classes or any type of family therapy because of this very erratic schedule. In addition, this erratic schedule really triggered the 8-year-old because the 8-year-olds need stability. They need a schedule. Also, in addition to working fast food, she had to do DoorDash in order to try and make ends meet. Because she had limited childcare, the 5 children would ride with her door dashing late into the night, which means that homework didn't get done. Baths often got missed, and they often missed school. So the mother would get put in jail for truancy. For 3 days, the children would be left with a family member for 3 days until their mom would get out of jail. So in order to try and keep her children, she ended up getting into a relationship with an individual who was extremely abusive and started exposing the children to sexually inappropriate materials. And then at that point, CPS had to get involved. 4-year-old being seen, again, it's aggression. This comes into the issue with childcare. This 4-year-old has no appropriate childcare. They need some type of structured therapeutic childcare at 4. There is no real funding for that. There are no real programs for that, especially if the families can't pay for it. MAP team paid for this child to try and be enrolled in an after-school preschool, but the child, due to aggression and behaviors, was kicked out and ends up having to stay with a grandmother who goes completely against everything that the parents and the therapist have tried to put in place. So now they're on a waiting list for MyPAC services, and that waiting list is relatively long, unfortunately. And this is probably, one of the saddest stories, I think. So we have Sunflower Landing. We have a 17-year-old in treatment. She was brought from the Juvenile Justice Center directly to us. She's also in CPS custody. She is a chronic runaway. She tries to run away every place she is, so much so she's at least cut off 2 ankle monitors. The judge is now looking for some way to get an ankle monitor that's basically impossible to cut off, but this kid is very smart. The parents are both addicts. Father was in Parchman for most of her life. Mother lost the child to CPS because of her own addiction. So the child has been living with her 32-year-old boyfriend after breaking up with their 56-year-old boyfriend, who both have fed her drugs consistently throughout the times together. The 32-year-old they figured out how to sneak him into hotels where CPS was trying to keep her safe because they didn't have foster placement or emergency placement for this child. They would put her in hotels, and kids are brilliant. And they figured out how to sneak this 32-year-old into this hotel where she was supposed to be safe. She overdosed and almost died last year. She's attempted suicide also within the past year. Right now, what are we going to do with her after we get her treated? So she's dropped out of high school. We're working on her GED. We're trying to help her understand appropriate and inappropriate relationships. We're trying to use trauma-informed care to process the trauma that she's experienced. But where does she go next? And that lies in one of the biggest gaps that we have in Mississippi is mental health supportive housing. So ultimately, we come into contact with people that have all types of needs, not just mental health needs. That seems to be where we meet people, but then we meet them and we realize that they have needs in all domains of their lives. In order to help our families, I really think that we need to be able to find a way to help get food, shelter, and safety, because those are the things that our families seem to not have. And that shelter is one of the biggest ones. I think that sometimes we continually focus on just the term mental health, and we focus on therapy and evidence-based practices and all that. But again, if we don't have homeostasis, if that bottom piece of Maslow's hierarchy of needs is not met, I can provide therapy all day long. I can provide the best therapy on the planet. It is not going to change a behavior because that bottom line is not met. So I think that some of the things, in my opinion, that the state can consider is how can we ensure expanded insurance coverage for families? That is a significant issue. Again, almost $8 million in uncompensated care. If we were reimbursed half of the uncompensated care that we provided last year, I could have twice as many therapists and I could give them all enough money to where they wouldn't want to go to other treatment providers. How can we build these facilities and grow the programs we already have and duplicate some of the programs we already have, such as additional substance use treatment facilities and additional crisis stabilization units? How do we ensure stable housing? How do we make sure they have food? How do we work to make sure that there's childcare available? And so you've got some children who, of course, they have younger siblings, and you have families come in for family therapy and there's nowhere to place the younger sibling. It's hard to have family therapy with a 4-year-old bouncing up and down. And then while we figure these things out, I really appreciate you guys asking the Community Mental Health Center to come in here and talk to you guys. Please don't forget us while we figure these things out. We really are on the ground. I was joking when I came in and I was like, I don't even own dress pants anymore. And the reason is because I never know if my day is going to end in a field with a crisis getting eaten alive by mosquitoes or not. And just yesterday, we had an 18-year-old coming into residential treatment who overdosed in our parking lot. And so I was on the ground and luckily he survived. He was completely blue, but he survived because we have tons of Narcan. But this is what the community mental health centers are dealing with every day. So please invite us to come in and talk about those things. Things that you guys could do is help us obtain physical facilities, help us renovate facilities that are already there, help us purchase facilities, even if we're purchasing it as a county, allowing the county to purchase something and then lease it to us. But that's one of our biggest issues, is finding a spot to do treatment. Ensure that schools are directly partnering with CMHCs. Other private providers, there should always be choice. I think that choice is important. But when you're talking about governmental agencies, community mental health centers are the local mental health authorities, and we are tasked of providing all the services that you can possibly provide, whether somebody can pay or not. And having the schools partner directly with us, it reduces it makes a stable environment for the teachers. The teachers know exactly who to talk to. It makes us stop having to fight for rooms. Some of the schools that we're in that have also partnered with private providers, we end up trying to schedule times inside one room that the school can provide. What ends up happening is on both sides, our kids don't get seen. So I think that there needs to be consistency there. Create a program of permanent supportive housing for individuals with mental health needs. And I think that this needs to happen all across the state. If we don't have this, the mental health problem is going to continue. Recommend a partnership between the local CPS and CMHCs. I know that at the state level, there's a great partnership, but what I have found is that some county CPS offices are wonderful. They're fabulous. They are the first ones to call us. And then throughout the state, you're having to find the CPS worker. You're having to figure out how to contact them. And, I have almost 350 employees. So I completely understand an employee not doing what my expectation is, you know? But I think that if we were forced to have more of a partnership on the local level, it may help, you know, make things a little more consistent. Create parenting programs with a funding stream that allows monetary incentives for parents to actually come. And I'm not talking about a $20 gift card. I'm talking about $200, $250 for them to come to a class, because that means that they could take a shift off work and not have to, you know, decide not to eat. How can we make sure that the families have the funding to skip a shift and get the treatment and education that they need through evidence-based parenting practices? And then fund additional parenting, pregnant parenting programs. Fairland is the only one that we really have right now in North Mississippi. The other ones are in Middle and South Mississippi. They're all full all the time. We at our residential treatment facility, we're able to keep a pregnant female until they give birth, but they need to have another place to go to. So creating more of those programs and funding those programs, increasing the bed capacity would be a fabulous thing for the state to do.
A question I forgot to ask Wendy, but you're here now and I know you know these results. One of these reasons that these programs are so important for pregnant women to have is the efficacy rate, and I know is very, very high on women who get treatment while they are pregnant and then after they give birth. Do you know those efficacy rates? I know it's really high.
It is very high. I don't know the specific percentages, but I can tell you also, though, that the efficacy rates in pregnant females who go to treatment and stay in treatment, it directly aligns with the efficacy rates of individuals going into treatment and staying for long periods of time. And so we've really kind of, as a nation, gone into this ASAM model, which is, you know, a level of care model where you move between these levels of care. But really what just anecdotally I've seen in over 20 years, and I've provided substance use treatment for over 20 years, those individuals who can go through treatment 30, 60, 90 days, and then have true supportive housing where they're not having to pay for the housing. They have a mental health provider in the house constantly. They're required to continue outpatient treatment. They're required to make sure they have medications, which is essentially what they do in the pregnant parenting programs. These individuals have a much higher likelihood of remaining sober at the 5-year mark.
Senator Bryan, I'm going to start with you. You had a question earlier and that I think I'm going to let you start with you.
If I am an adult and I'm destroying my neighbor's property and they call the police show up, it appears that I have some mental issue going on. My understanding is they send for the crisis intervention team, and one outcome would be that they would take me to the crisis stabilization unit.
Yes.
If I'm a child and I'm doing the same thing, do the police call the crisis intervention team?
Yes, in my area, and I know in most areas that they should. I think it depends on the relationship between the community mental health center and the law enforcement. With the creation of CIT, those relationships are getting stronger and stronger. So in my 6 counties, they absolutely do. They call us 24/7. It's 24/7. We go into the schools when a kid is, you know, is in a mental health crisis. We go out to the homes. We, you know, wherever the crisis is, that's where we go. We typically send at least one therapist, one CIT officer. If the crisis is, and I joke with our CIT officers because I kind of wanted to be a police officer at one point in my life. So if there's like guns or, you know, weapons, then I usually go because I like the adrenaline. It's like, oh, I don't know if I'm going to live through this. It may be kind of fun. So we often will send multiple people depending on the size of the crisis. But yes, I mean, we go out no matter child or adult.
Well, let's say it's Saturday afternoon and the team shows up and the child obviously has mental issues. What do they do?
So right now, because there is only one adolescent crisis stabilization unit, and they're usually full, we are doing our best to try and move along to get ours built. But again, it comes into that renovation type stuff. So what we would do is we would go to the home, we would work with the child. Is there any way we can make sure, just de-escalate this crisis in the home? Can we create a safety plan with the parents and with the child? Can we create, can we put it on paper and say, okay, child, you're going to do these things, and parents, you're going to do these things, and then you're going to call us back if this isn't working, or we're going to see you, Monday morning at 8 o'clock in our office, and you're going to see a physician and you're going to see another therapist to see what we can do. If there is no way to maintain safety for that child or the family at that moment, we will work with acute care hospitals who accept Medicaid or private insurance, and we get the child placed in that hospital. So right now, sometimes the parents will take them. Some of the acute care facilities will provide transportation, and sometimes our law enforcement will provide transportation. Depending on the level of crisis, our mobile crisis response team has also provided transportation.
But in short, the community mental health center takes responsibility for that individual.
Yes, we do.
So if the child involved is doing the same thing and the child winds up at the youth court, and at the intake process or whenever it comes to the attention of the youth court that the child has mental health issues, why would not someone at the youth court just call up the community mental health center and say, this person has mental issues, take it from there?
In our area, they do. So some of our courts have a staff member, have one of our staff members inside the audience of every youth court hearing that they have. Some of our courts don't, it just depends on what county. But our judges do, or their staff, they call us and they say, hey, we've got this person, here's their contact information, can y'all figure this out? And then that's what we do. We contact the parents, we do assessments, we try to get them enrolled in services. And for our agency, if the parent refuses those services, then we immediately notify the judge's office and we say, hey, we attempted to do these three things and the parents are refusing. So at that point, unfortunately, the ball kind of is back in the judge's court because we can't force the people to have treatment. But our relationship with most of our judges is they court order it and then they kind of have to. So we get back involved.
Well, the two judges that were here yesterday, as I understood it, said that they could not pick up and call the community mental health centers because we were talking about children, not adults, and that nothing would happen if they sent them to the community mental health centers. And therefore, the judges, take it upon themselves to keep a list of providers, and they start trying to place the child and on and on and on. Mm-hmm. So is my description of what happened, you're nodding. Are you agreeing with my description of what the youth court judges said?
I did, and I
Oh,
think,
good. You're agreeing. Let's just stop there. But all I want to say is that it's in listening to people and holding hearings in this issue, frequently what we hear are several things. Number one is this is the way it's supposed to work, but it may or not be working that way in any county, let alone all 82. And then as you go from county to county, just like here, we've got different things as you go from community mental health center to community mental health center. The other quick question I had was, you have a crisis stabilization unit at Batesville. And what happens if someone in Tunica County needs a facility and all the facilities seem to be full? Do you ever take people from other counties there? And if so, how does that work and how does the payment work?
Yes. So let me back up just a little bit. The youth court judges, I think that my recommendation on that is to somehow force a communication. So our youth court judges are easy, they pick up the phone and call us, I think because we have a really good relationship with them. I only have 6 counties. So it's easy for me to go to courts and say, hey, I'm Melody, this is what we have. Here's my cell phone number. Call me if one of my staff don't do what I'm telling you that we're going to do. And because of that, I think that there's trust there and it's easy for them to access services. In terms of the adult CSU, we take people from all over the state all the time. Sometimes we actually end up having more people in other counties than we do within our own catchment area counties. And that reimbursement, so most people don't have insurance, so we're not reimbursed at all. The state does provide, funds for us to run the CSU. Last year, my CSU did run at about a $300,000 deficit, even with the funds being provided. Because typically when I look at my census, usually on average, out of 16 people, there may be 3 that have insurance. And then with the insurance, you've still got to get prior authorizations. And so if you call and make a case that this individual needs inpatient or CSU level care, the insurance also has to agree with that. And if the insurance doesn't agree with that, then they don't reimburse you. You can file appeals, and we absolutely do. And every once in a while, we'll get it reversed. But for the most part, if the insurance company doesn't believe that this person needs this level of care, they won't pay for it.
Do the other counties reimburse you or send you any payment if you're taking care of their individuals?
No.
Do you know if anybody does that or if that's a feasible thing?
I don't know that anybody does that. I think that most of the counties across the state reimburse or provide some funding to each community mental health center that makes up their catchment area. And when we start talking about the funding issues and the vast differences between the community mental health centers, I feel like I have some of the most amazing counties in the state, and I love them. But the most I get from one county, from all 6 counties, the most I get in a year is $78,000. And that's all that the county reimburses us for providing services. We provide services to about 6,500 people in our 6 counties. So some counties just don't have the money to give. And those counties are providing monies to their local CMHCs to provide services. So no, we don't get any money.
Thank you.
Additional questions? Senator England?
Thank you, Madam Chair. I have a question, but I'm going to describe a situation that was told to me, and I just want to know if you're seeing the same thing, just so I know if this is statewide. When Senator Wiggins and I had a chance last off season of the legislature to meet with superintendents from the different schools in Harrison County and Jackson County, Stone County, coastwide, really. And they described a problem that I didn't know we were having in schools, which was with violent kids in elementary schools, and they were, striking their teachers. And so then they described to us that they have to then take these kids and take them out of the classroom, and they would take them, I think they said, to Pine Grove sometimes, and just try to find a place where they could take them for a time period. And and they described this as a very big issue. And because, they would take these kids, they would say, your kid can't come to school anymore. They're being too disruptive. They're striking teachers. Are y'all seeing that? And is that something that requires inpatient treatment, or, does it require beds or something else? And then I want to make just another statement and ask your opinion on this. I've been listening. I haven't been here, but I've been listening to all of our speakers, and I think everybody's done a great job. But I feel like we're hearing a lot of symptoms to maybe a bigger problem that I don't know that's been identified, or if it can be identified. But we talk about money that's needed and resources that are needed and all of this that's needed, but it seems like we're treating symptoms, and there's just something. I don't know if this has always been a problem, and maybe you can tell us that. But how do we address that issue, if you know, and look, I know I'm putting you on the spot because you're the speaker that I'm sitting here with, but,
Yeah, no, that's good.
but just if you could talk on that,
Sure.
thank you.
So with the first question, we do see kids in elementary school that are violent. I know that at least one of my school therapists last year had to take off because her eye got busted by an elementary school kid. And that does seem to be increasing. And yes, there needs to be specific beds for that younger population. So residential crisis stabilization units, residential treatment facilities, things like that are usually like 12 and up. And the state is the only place that really has those specialized beds, and there's only a couple of them. So there does need to be more programs, more facilities that specialize in that young population. And I can't not talk about this, and it's because it's something near and dear to my heart, is I don't think in the state of Mississippi that we are screening and treating autism well. We do not have early intervention programs. My son's autistic, and he would get so mad if I told everybody that, because he's like, don't tell people I'm autistic. I'm like, well, you are. But when he was a child, when he was 2 and was diagnosed, we had access to fabulous early interventions. Fortunately for him, I had the means and education and ability to pay out of pocket for those services, to take off work for those services, to have an amazing grandmother who took him to those services. But my child at 2 was going to treatment 5 days a week for 2 and 3 hours. And now my child at 17 is in the top 10 of his class. He made perfect on the SAT in math. He's just got a letter yesterday and has a full ride to Alabama, and he has friends. He has these things, and I directly relate it to that early intervention. And I look back when he was a child, there were those violent episodes. There were those times when he just could not get out what he needed to, and it ended up exploding. And so I do think that in addition to some of these beds, I think that we need to somehow start providing these early intervention programs within our communities that are easily accessible.
And thank you for that. I'm glad to hear your son. I hate he's maybe going to Alabama. I wish we could keep him stay here.
He's not. I'm totally like
Okay.
against that completely.
Right.
I'm like, no, you're not going. I
Yeah,
want you to stay home.
Senator Boyd may disagree. She had one that just graduated. But so the early intervention, what was that? And look, I don't want to ask you personal questions if you
No,
don't want to
you're good.
answer, but
Yeah.
Was that a public school setting, or was that something that you had to pay for out of pocket to get your son that treatment? Because we have, particularly in my district, I have a lot of single parents, and I'm not alone here, a lot of single parents that are working 2 jobs to do the best for their kids. And I think, another issue that I think we're screening well for, but maybe not treating well is like dyslexia, right?
Mhm.
And so we have one school in Ocean Springs, and parents are able to either take off work and travel an hour and bring them there, or an hour and a half, or something like that. They're able to do it. So I just want to know what that early intervention school that you were able to get your son in that was so successful, what that looks like, and how maybe we can replicate that in a more public arena, that we can get that more available. What would that look like? Because again, I mentioned, I feel like we're treating symptoms once we
are.
get beyond a certain point, and we're not treating an actual problem, where our money could maybe be spent better treating the problem.
Absolutely. So for Brendan, his day, so part of it was treatment that was funded at UAB. We lived in Birmingham. That's where I'm originally from. So I moved here about 13 years ago and could never go back. But UAB had some grant funding that allowed for early intervention programming. So he went there a couple of days a week. He did take advantage of the Head Start program in Birmingham, which was very helpful. He went there a couple of days a week. And then I paid out of pocket a private BCBA therapist who basically, he and I would go, and it was really my therapy, because he would go play and I would try to intervene or say something, and she would get on to me because I was doing it wrong. And, and I had a master's degree with a master's thesis in autism, and I still didn't know what to do. And so she was telling me, no, you can't talk to him that way. So a lot of those therapy sessions ended with him playing and me crying. It was like, it was mass chaos, but I had to pay out of pocket for that. So I think that if there was a way to create those programs, and maybe not, quite as intensive, I think we start out with small programs and then we grow it. But right now, where I am, there's nowhere to go. So if you've got a parent that doesn't have transportation or is working multiple jobs, they don't really have access to that early intervention. And you want me to answer the other part of that?
Well, maybe, but
Okay.
let me just say, so you mentioned Alabama, and so you have some familiarity with another state, and I always like to look and see what other states are doing.
Yes.
Do you know if there are any sort of, and I know this is a bad word for a lot of people, but like voucher programs or something that allow for parents such as you that may not have the means to do something like that? If you have that capability, if you have the ability to do that as a parent, would we maybe see facilities arise because the funding is then available for a certain area to do it? Was that possible there in Alabama?
I think that's definitely possible. I don't exactly know what Alabama had because it's been 15 years and I don't know what they're doing now. And I didn't have to look into any of that. I do know that across the country, though, there are programs like that ensure that individuals with a diagnosis of autism have access to early intervention, whether the family can pay for it or not. And so, and the other question about how do we fix it? I don't know, but I do know that anecdotally, when I see children succeeding, I see children in a really stable home. I see children that know where they're going to put their head at night, that absolutely know that I'm going to get dinner. It may not be Dino chicken nuggets, but somebody's going to feed me dinner. You know what I mean? And it's these children whose families are sitting down with them at night because they have the time and the ability and helping them do the homework, even though math makes no sense anymore. But they're trying and they're helping. That's what we need to fix. And housing is a significant issue. And that's one of the biggest things that I think we need to start with to fix that. Now, how we fix the housing, I don't know that, but I know that if we could somehow help with this, with the significant housing issue, I think that the symptoms would decrease and we would actually be able to treat the true mental health issue instead of just putting Band-Aids on all the symptoms.
Thank you so much. I'm going to have to cut us off because we've got NCSL that has been patiently waiting, I think. Thank you, Dr. Medeiros.
Yes, thank y'all for having me. I appreciate it.
Appreciate it. And to the Senator England's question, we do have ESAs that are operating very robustly, trying to kind of look at that. But early intervention, glad to hear your support for that. So NCSL, are y'all available right now? Can y'all hear us?
Hello, Senator Boyd. Yes, I can hear you. Are you able to hear me?
We can hear you.
There we go.
Y'all, we have Tammy Hill and Kathy Wells, both here. Tammy is the NCSL Health Programs Project Manager, and she has been a great help to us. And then we have Kathy Wells here, who's the Executive Director of the Kemper Center for the Prevention and Treatment of Child Abuse and Neglect. And we thank y'all so much for waiting on us today. We've gotten very interested in these topics and we've asked a lot of questions. So thank y'all. And if y'all will go ahead, I'm going to turn it over to y'all.
Thank you so much, Senator. Really appreciate it and appreciate you letting us listen in as well. I think it's valuable context and it's nice to hear what other discussions are happening. I'm going to turn it over to my colleague, Dr. Wells. She is the Executive Director of the Kemp Center for Prevention and Treatment of Child Abuse and Neglect. And first, she's going to provide a clinical overview and help to draw connections between different systems that are interacting and how we can support women and families experiencing challenges with substance use. After Dr. Wells, I'll do a brief presentation around legislative policy considerations in this space and then turn it back to you all for questions. If that's all right, I will turn it over to Dr. Wells and have her share her slides.
Hi, Madam Chair and members of the committee, and thank you for having us here. I think it's still morning there, so good morning, and appreciate the opportunity to address you. I'm going to share a few slides, so I hope that this works, but please let me know if, let me just go to, let me know if you're seeing are you seeing the slides there?
We are seeing the slides now. Thank you.
All right, great. Well, again, thank you very much for the opportunity to address you about a topic that's been near and dear to my heart for over 20 years, working in the space as a pediatrician and a child abuse pediatrician. I hail right now out of Colorado, but I am the director of the Kemp Center, which is the oldest institution that has been addressing issues of prevention and treatment of child abuse and neglect. And my particular interest has been in the interface between substance misuse and abuse and neglect. And so just briefly, our center, we sit within the University of Colorado School of Medicine. And as I've said, we've been around for over 50 years. Dr. Kemp started our center at a time when people didn't really realize that abuse and neglect was occurring in the way that was. And really now the work we do spans everything from direct clinical care, consultation, training and education, research, policy, and we're doing all of that with a justice, equity, diversity, and inclusion lens. And so there's our website, and you can seek more information. We also have a supportive foundation. But I say that just to give you context that I try to bring the view from multiple systems. So I am a healthcare provider at my core, and I really believe that these issues are grounded in health issues, and we'll talk about that. But really multiple systems are involved, and really appreciate your interest in what you can think and you can support in doing better, because there are a lot of nuances. I can tell you in the over 20 years I've been involved in doing this work, my mindset has evolved significantly in terms of my early days of taking care of babies that were born to moms that were misusing or abusing methamphetamine, to really understanding the complexity of the entanglement of social and societal beliefs around substance use disorder, and how that plays a context within our friends, our families, our communities, as well as how it impacts our children. So the other thing I think it's really important to understand, and I did appreciate hearing some of the comments from the last speaker as well, is that these are really complex issues. And when we're really talking about substance use in pregnant and parenting persons, trauma is almost, if not 100% of the time, embedded in what may be impacting that situation. But as a pediatrician, you know, I think about what are the places where we see substance use in the home impact our children. And really, it's everything from obviously prenatal exposures and what that means, and the co-occurring stressors that may be happening in the caregiver, all the way to other risks that might be happening in the home related to that drug use itself, distribution, manufacture, or criminal activity. And so I like to frame this in just sort of for you all, if you're not aware, that as it relates to the complexity of child abuse and neglect, these are issues that have been going on for a very long period of time, right? And when we talk about the challenges that someone who is parenting and has a substance use disorder and potentially placing their children at risk, and the interface of child abuse and neglect, we have a lot of challenges in terms of addressing this. So we have some timelines that have been put in place in terms of permanency and safety for children that are at risk, that are really implemented through the Adoption and Safe Families Act that have been in place since '97. But we also have the developmental needs of the infant or the child. We have the limitations and accessibility to treatment resources, as I think you were all hearing about. And then we have the fact that we know substance use disorder and addiction is a chronic disease. And so we have to think about it like other chronic diseases, and that means that there is relapsing and remitting aspects to it. So someone might be very stable on their asthma treatment, and someone else might struggle with relapses, and substance use disorder is no different. And so I put this up because really my early work in this area was sort of underscored by what was happening nationally in recognizing these challenges. And the Center for Substance Abuse, National Center of Substance Abuse And child welfare was really established out of some of this recognition, has done some amazing work in this space as well. And also further grounding and understanding some of the legal or the context in terms of laws that are impacting our major systems is to understand that in 2003, the Child Abuse and Prevention and Treatment Act, when it was reauthorized, so that's funding that goes to the states to receive funding to support their child abuse and neglect prevention and treatment programs, really established some state responsibilities that were related to prenatally exposed infants. And that was sort of the first time that we saw some language tied to funding to the states to support prevention and treatment around this issue. And this early language really required the states to have policies and procedures, and this is all states, including appropriate referrals to child protection systems and other services to address the needs of infants born and identified as being affected. And the early language is just listing illicit or illegal substance use or withdrawal from prenatal exposure. And that it did require healthcare providers involved in delivery of care of the infants to notify Child Protective Services. And so a couple nuances here. This is funding going to the states for their child welfare services, but it required something from healthcare providers. So perhaps you can understand why I was interested as a healthcare provider to say, we as healthcare providers do have a responsibility to our patients, but we're not bound by these sort of rules. However, early in those early days, there was a real desire to understand how does that interface work. And then the word notify is bolded here because it depends on different state laws whether there are ways to, are these all reports to child welfare, or are they, is there a system where there can be a notification if the mother is actually stable in her substance use disorder, but still would have a baby that tests positive because maybe she's on medications to treat her disorder and is doing well stabilized. This also required what was called a plan of safe care for any infants born and that were affected by, again, early language as illegal substances and withdrawal, and then a referral if there was imminent harm to community, if no imminent harm to community organizations, but if there was imminent harm to child welfare. So this was some time ago, of course, and there have been some modifications. So CARA, which is the Comprehensive Addiction and Recovery Act of 2016, that did a couple things. It added criteria to plans that really included now not just illicit substances, but actually included alcohol, because we know that has a tremendous impact on the unborn infant and on parenting. And then in 2018, the amendments allowed grants to states to facilitate collaboration in developing and updating and implementing and monitoring plans of safe care. So this is really what started to say to the states, you need to have plans in place and you need to monitor this and you need to know what's happening in your state. I bring this up because I think this is really some context in terms of where the state human services entities are in terms of funding for programs to support pregnant and parenting persons that are using substances. But stepping back as a pediatrician, I think we have to think about the larger context about how are we doing in terms of our multiple professional and other entities in terms of supporting these children and families. What we do know is that about 11% of births nationally are affected by prenatal exposure to alcohol, and about 8% are affected by prenatal exposure to illicit substances. So we're not talking about an insignificant number of children. And to think about that context, I think one thing that was important for me to grow in my journey in this area, as a pediatrician, I was, really focused on what needed to happen to protect that child. But really understanding that someone who is pregnant and is using substances is typically someone with an addiction who got pregnant. They didn't start using during their pregnancy, right? They often desperately want a healthy baby. They're very consumed with guilt. They're very sensitive to any symptoms of withdrawal. So if it's particularly things like opioids, they may be very worried that their baby is now going to experience withdrawal and interpret certain symptoms or certain behaviors as possible withdrawal. We have seen times when someone then actually gave the drug to their child because they were worried that they were having withdrawal or wanted them to calm down or quiet down. they may be very accustomed to feeling disrespected. And so that anyone that really treats her in the context of respect and dignity is really going to have much more effectiveness in really getting her to engage. And then there really, as I said earlier, is almost across the board some sort of history of trauma that if we don't address these needs with a trauma-informed, culturally responsive approach, we're going to have really limited ability to sort of be effective. But we also know that someone who is pregnant, or even someone who's considering pregnancy, might be we know is a very, very opportune time to give them an incentive to quit. It's also a very stressful time, and it's a very short time for substantial behavior, social life, and relationship changes that might need to occur to effectively address the substance use disorder that might be going on. And we also know behavior change is really challenging, right? So anybody that's ever tried to even just give up chocolate for Lent or whatever the thing you're trying to do, it's challenging, right? And especially if you're talking about an actual disease process called addiction, and everyday life stresses tend to compound that. It's also further affected when we know with the mega stresses of poverty. And so we know, and we can assume that there will be many attempts before someone is successful. There's going to be relapses and backslides and false starts. And I struggled with this early on as a child abuse pediatrician because I remember thinking, so if we set up a relapse plan for someone, are we just giving them permission to start using again? And someone, a colleague of mine really helped me understand this to say, when we set up fire escape plans for homes or for businesses, we're not assuming there's going to be a fire. We're just understanding that if there's a fire, we want a plan in place. And so I think it's really important to understand that the context of this is a chronic disease, and that it may feel frustrating because sometimes someone seems committed at sometimes and not others, but it really is related to these other host of factors that make it very, very challenging. And we also have to remember that substances are a wide range of things. It's not just, methamphetamine and opioids, but it's also legal substances, alcohol and tobacco. Marijuana, I believe, is recreational marijuana is not legal in Mississippi. It is in Colorado and other places, so that tends to move. But really, we are really advocating for focusing on the impact of the substance, even if it's a prescribed medication, even for good reasons. What's that impact, as opposed to whether it's legal or illegal. And the other challenge is that oftentimes substances aren't used alone, right? So there may be multiple substances that are being used. And we want to be careful that I don't try to convince someone to quit using cannabis, but now they turn to alcohol because we know that's honestly the most damaging to the unborn baby. And we don't have the best data, unfortunately. There's lots of reasons for that. People are fearful of being prosecuted. They're fearful of being involved in child welfare or having their children removed. And so that impacts not only our ability to get great data, but also oftentimes utilizing appropriate medical and treatment resources. So where's that balance between creating a structure so that we can ensure that people will seek the services that they need? So for example, in Colorado, early on in my work, we passed legislation that said, women who disclose their substance use during pregnancy or are found to be positive during prenatal care, if that was the only thing, it wasn't like a car accident or something, that could not be used to criminally prosecute them. And we really wanted to do that because our healthcare providers were telling us that there was a lot of fear of prosecution. And there's also a lot of fear of losing their kids. But it's really important, the earlier that we can identify these risks and the substance use in the pregnant parent and parenting person, we can really reduce the risk to the infants. And so when I talked about it really being hard to get the good numbers, it's that social stigma, it's that fear. Self-reporting. Oftentimes, if someone does report their use, they're going to under-report, or they're going to maybe report the substances that they feel are less worrisome to the person they're reporting to. So they may not tell us exactly what or how much they're using. And then hospital policies and procedures have been really not uniform. And that's everywhere I've gone, everywhere I've spoken across the country, this has been a challenging problem in communities. And then even testing is not perfect, right? So there's lots of reasons, we want to just do a test. Unfortunately, that doesn't always give us all the information, and there's a lot of challenges with that. So what are the numbers, right? And so the best we can do is looking at things like treatment admissions. So this is some data you can see. I sort of highlighted Mississippi data that about When you look at treatment admissions for women of childbearing age who are pregnant at entry, about 4.5% in Mississippi. So those that are actually entering treatment, we know a lot of folks are not getting into treatment, either accessibility or their fears and telling us what's happening. And we know that the effects are going to vary widely. I have met folks that have used substantial amounts of substances during pregnancy and the babies seem to be doing well. And I've met other folks that have used far lower numbers and have had kids that have had challenges. It's very difficult to predict, and there's a lot of factors that you can see listed here. But I think that one of the things we really need to be clear about is that there is no known safe amount of drugs or alcohol during pregnancy. We know alcohol is the most dangerous to the baby's brain and body. And we know that there's a lot of other confounding variables, right? So if we can at least get mom to get good prenatal care, that alone will improve the outcome for the baby, as well as things like good nutrition, good weight gain, and then a nourishing environment where she's living in. I heard comments earlier about things like stable housing, and it's absolutely what we're seeing is that sometimes Maslow's hierarchy of needs, you got to deal with the things that are on the base. And so it might not be that I can engage her in a strong treatment program right now, but if I can just get stable housing and good prenatal care, the outcomes for the baby are going to be better. And so we know there are lots of problems that we can see in mom, and I won't go through this exhaustive. There's a long list. It can complicate mom's health, and that can complicate the pregnancy itself or labor or delivery. And there's a lot of things, not just the actual substance use itself, but other coexisting challenges, victimization, poor nutrition, other health complications. And then the effect on the baby is entirely dependent on a multitude of factors. So when in pregnancy she used, how much, what substance, how she used it, how often she took it. Major birth defects tend to occur earlier, but we know that the brain and growth is impacted throughout the pregnancy. And so one of the things that's really clear, and I've had, when I was in practice, I had people even coming to me saying, they wanted counseling on abortion, which I clearly did not do, but they were afraid because they were using substances and they thought that it was already too late to get help. And so really helping people know that at any time they can get support and services will have a positive effect on the baby. And so what are the general problems for the baby? There's a large range of problems, everything from babies that are born early and have complications related to that. They can be small. They can have some physical dependence on the drug. They can get infections. And there's really an increased risk of death. And that's very, very clear from the data. And this is a chart that I don't expect you to see, but I have a reference here at the end, and I'm happy to make available if folks want to see in more detail. But there is some good data on, depending upon the drug of exposure, what the effects are on fetal growth or congenital problems or withdrawal, neurobehavioral problems in the infant, long-term effects. But I will tell you that I wish we had more data. It's just very, very difficult to do these kinds of studies. What I can tell you is that by the time mom identifies that she's pregnant, okay, she has her first missed period, if she even identifies at that point, we've already started to see the development of the brain occur and the development of the heart. And by the time she sees the first prenatal visit, you can see all body organ systems have started to develop. So this is also why that early on education and supports are really, really critical, because by the time she even gets to the place where we can, as a medical team, identify, oftentimes things have already started to develop. And then we know that there's increased infant mortality, right? So the data is very clear on maternal mortality being related to substance use disorder, that we're seeing increased rates in our country, but also babies are at higher risk. Everything from unexplained infant death, positional overlie, premature death, and severe complications. So we talk about this a lot in our state fatality review team about the increased risks. And then the effects on the growing child. So very difficult to study, because I can't sort of line people up and say, you folks, you just use methamphetamine, you just use opioids, you just use alcohol, and we'll control everything else. But what we do know is that these children can go on to have some executive level functioning challenges, really understanding the connection between something that they're experiencing in their behavior. They also have difficulties with problem solving and memory, attention span. Some of these kids will be identified as being attention deficit, which frankly, it may just be related to their prenatal exposure. And then we see challenges even as they get into their later childhood and teens. And, you know, again, how much of this is genetic predisposition or epigenetics, so environmental exposures that change our genetic expressions, all the way to environmental exposures. But it really becomes a bit of a cycle. And if we're going to break that cycle, the earlier we can really address this, the better off we're going to be. And so back to our sort of other risks, and just to touch on, you know, the data is about at least 12% of our kids live with at least one parent who's in need of substance use treatment or alcoholic. And those kids can go on to have challenges, right? They're more at risk for abuse, they're more at risk for neglect, and they're greater risk of using substances themselves. And part of that is because we know that when someone is using substances, it affects their ability to have connection. It impedes the development of relationships that are essential for kids to thrive, that sort of serve and receive and those sort of bonding things that happen with a parent and a baby and children. Parents may not have the best self-regulation. They may be maladaptive in how they respond to different stressors like parenting, especially if they have other stressors that they're facing like housing instability, food instability. And then that may interfere with their ability to have healthy relationships. And some of the outcomes that they may experience related to things like depression or other psychiatric disorders that they might even be self-medicating with their substances. So we see impaired attachment and impaired judgment, inability to provide consistent care and supervision and necessities. And so for that reason, we know substance abuse is a critical factor in child welfare. And this is some data that comes out of that National Center on Substance Abuse and Child Welfare that I mentioned earlier that has really been tracking. Now, data unfortunately lags, as you're probably aware, but the data really shows that we've seen a steady increase in prevalence of alcohol or drug use being identified condition of kids being removed from their homes. And this has been over the last 20 years, and we've continued to see these rises. This is actually data, I tried to highlight Mississippi data on parenting, parental alcohol or drug use being a condition for removal of kids that are 1 and older. So in Mississippi, it's almost 50%. And if you look at kids under a year of age in Mississippi, it's almost 60%, with the national average being about 51% of kids being removed from homes, going into foster care because of concerns of abuse, drug abuse or alcohol abuse. So, you know, the impact on the caregivers I've touched on. So it's everything from a caregiver being impaired or the environment being dangerous. And I just wanted to note a couple other things. We've seen, you know, obviously a significant rise in opioid dependence. This was one study that looked at specifically opioid dependence. Again, that disorganized attachment, avoidance of what needs to happen for the kids' needs, irritability, disinterest, ambivalence. So just really, you know, substantial concerns and really what people can do when they're struggling with this. And so this is why we really need to think about this as early as possible and then think about programs that really can wrap around this family as much as possible if the child is safe at that time and we can create safety. As I mentioned earlier, sometimes the only legitimate social role these folks will tell me is being a mom. And they're really concerned about how their substance use is affecting their children. And so I think it's an important opportunity to think about what can we do to support and create support services and treatment for pregnant women. Because as I said earlier, outcomes will be better when the woman has received both substance use treatment and prenatal care during her pregnancy. But that treatment needs to be tailored to their needs. It needs to be trauma-informed and culturally responsive. There need to be support services and resources to address all the other challenges that mom and family might be facing. It needs to not just be the mom, it needs to be everyone around her that is going to be that safety net, that family to encompass her, to support her being able to safely parent that baby as a family, and really encouraging them to have the parenting skills that sometimes they may not have had growing up. So I really think about that intervention has to be everything from pre-pregnancy and prenatal at the time of birth, which is a the time we can name, but there's so many things that can happen before and after, and then throughout childhood. And then those will be our next parents, right? Those will be the community that is raising our next generation also. And this really requires us to be really collaborative, right? So thinking about everything along that continuum of prevention, intervention, treatment, everything from pre-pregnancy through childhood, and education and treatment are critical. And we know that one agency can't do this alone. I look back to my predecessors. Dr. Kemp used to say abusive parents love their children very much, just not very well. But our task is to help them do better. And I think the other thing I always try to go back to when I'm working with families that are struggling with this is that if we don't understand what's going on, we don't often have enough history, and we really have to think about that in the context of changing the cycle of trauma and abuse. Just a couple things. Well, I'll share this talk so that you'll all be able to reach out to me directly if you have additional questions. And I want to turn it over to Tammy to present the next piece of information, and then I'd be happy to answer any questions.
Thank you very much, Dr. Wells. I'm going to just take a moment here to share my own screen. I believe the request was sent. There we are. Is everyone able to see my presentation slides?
Yes.
Wonderful. Thank you so much. Well, thank you again, Madam Chair, for having me, and to the committee members. As stated, my name is Tammy Hill, and I am a project manager with the National Conference of State Legislatures Health Program. Before we jump in, I do just want to take a minute to highlight who NCSL is for those that may not be familiar with us. We are the nation's leading bipartisan organization for all 7,386 state legislators and over 30,000 legislative staff throughout the US, DC, and the territories. We work to really improve the quality and effectiveness of legislatures, foster cooperation, and facilitate information exchange and promote innovation. In this capacity, we work to support members like you on this committee in bipartisan research and training opportunities. We do not advocate to states, but we do represent and advocate for them at the federal level. We also work to foster connections between states and experts like Dr. Wells. For today's presentation, I'm going to move rather quickly, but we'll be providing context for 3 different policy spaces and legislative trends or considerations for each of these areas. I would like to thank my colleagues on our civil and criminal justice team and our children and families team for their contributions to this presentation. First, I would like to go ahead and start with health. And as Dr. Wells really highlighted a good deal of what substance use looks like in pregnancy, I'll just go through a few high-level statistics currently, and we can breeze through a few of these slides. So first, we know that substance use or misuse during and following pregnancy has seen an increase over the last several years. In some of the most recent data from the Centers for Disease Control and Prevention and the Substance Abuse and Mental Health Services Administration, they indicate that an increase has happened for both prescription drugs, illicit drugs, and alcohol. The CDC has also reported that deaths related to mental health conditions, which for them does include substance use disorder, account for about 23% of deaths during pregnancy or the year following it. This slide here really just highlights some of those health risks that are associated with use or misuse of those legal and prescription drugs. And I won't go in depth since I know Dr. Wells also had these in her slides, but happy to go over any of this. Similarly to this slide, this really just correlates what are the more commonly used or misused substances and how do those tend to affect the development and growth of the baby or effects to the mom. So a variety of policy considerations are highlighted on this slide, and they're coming from a mixture of recommendations from both experts in the field, but also trends that we have tracked through legislative initiatives and programs. For actions related to prevention and intervention, there's a number of possible screening tools associated or that can help support with substance use identification. I think the speaker before really referenced SBIRT. That's the Screening, Brief Intervention, and Referral to Treatment. It's an evidence-based practice that providers, including OBs, can use to identify, reduce, and prevent problematic substance use and dependence. States are also working to enhance family supports through home visiting programs, night nurses, and doulas to help reduce stress and manage those daily life challenges and exciting moments with a newborn. And then states are also considering really that interplay between social determinants or social drivers of health that I think a few speakers have really talked about, highlighting the importance of housing or food, access to childcare, the hierarchy of needs, I think, as Dr. Wells put it. For treatment and recovery options, we know that access to care and continued screening is important, and this can include a myriad of things, but really a few that we've seen most commonly in this space are how to manage chronic pain for women. And the goal is really to stop or to minimize the use of opioids during pregnancy and to look towards other techniques that they can use to manage their pain. So some of those may be exercise, physical therapy, or behavioral health approaches. We also know that managing the use of pain through medications like buprenorphine and methadone can be safely prescribed to women in pregnancy. And the American College of Obstetrics and Gynecology, as well as SAMHSA, have also come out and recommended that treatment in conjunction with these medications for behavioral health therapy and medical services seems to be the best model at this time. I will also note that there is some data out there around the medication for opioid use disorder can result in infants being born with neonatal abstinence syndrome, and therefore it should be monitored upon birth for how these symptoms may result in a healthcare setting and how much withdrawal that infant may go through. And finally, plans of safe care or family plans of care, which I won't elaborate on. I know that Dr. Wells highlighted that, but again, really just helping to make that connection from the moment that the baby is born. And when we were listening, I'm going to just take a moment here. When we were listening to the speaker before us, we were talking about intervention programs or early Head Start programs. And I just want to say that Mississippi does have an early Head Start program that does serve all 82 counties. It's based off the income level, the federal poverty level, for folks that also can receive public assistance. If you have a child in foster care, someone experiencing homelessness, or someone that is pregnant or may become pregnant, as well as the Department of Health also runs the First Steps Early Intervention Program. So I think there are a few programs within your state that we would be happy to help you look into or make those connections if you're interested. So some state legislation in this space, just a few examples. It really includes establishing a targeted outreach program for high-risk pregnant women who may not seek that prenatal care, suffer from substance use or mental health challenges, and providing them with links and referrals to those services and information within their community. We're also seeing a number of states who are receiving some of that opioid settlement money, funneling it back into the community with evidence-based or evidence-informed programs, services, and supports. And then also working to improve the outcomes for women and newborns through either perinatal quality collaboratives or maternal mortality review committees. And then just a few resources from the health program. The legislative databases here will highlight what's happening within legislation in these spaces. A few reports that we've recently put out around postpartum period and care, and then workforce and how enhancing and supporting workforce can really help to identify and provide women treatment or connections to treatment in this space. And just a few federal organizations and resources as well. With that, I'm going to do a quick pivot over to maternal substance use and the child welfare systems. And so, as Dr. Wells highlighted, we know that parental substance use is a leading cause for removal for children in their homes. And over the past 20 years, parental substance use has increased as an identified condition of removal. It's especially true right now for newborns, infants, and toddlers. Children under the age of 5 are the fastest growing age group entering foster care, and about half of those kids enter out of home care because of the parental substance use. Amid this crisis, many states are looking for ways to support the comprehensive needs of mothers in recovery while keeping their infants and young children safe. The federal Title IV-E program requires states to make reasonable efforts to preserve and reunify families before removing the child from that home. All states have enacted similar legislation that require agencies to make that reasonable effort to provide families with services that will help resolve the circumstances that brought that child into the system in the first place. However, states do differ on their threshold for emergency removal. Some allow for such removals when there's a suspicion of abuse or neglect, while others allow for removal when the child's in imminent danger. In general, state child welfare efforts reflect a shift in greater child welfare policy toward family preservation, the well-being of both parents and children, and a collaboration between child welfare and early Head Start systems. We will highlight a few approaches that are taking shape right now in states, really around promoting recovery and keeping families together, access to family-based treatment programs, childcare, and home visiting throughout treatment and recovery. So family-based residential treatment centers allow parents and their children to remain together while the parent participates in treatment. In these homes, parents receive wraparound services to support and recovery and strengthen their family relationships. When mothers and children enter this treatment together, that parent-child bond is really maintained. And research has shown that women who enter residential treatment programs with their children are more likely to complete the program and maintain custody of that child. Under the Family First Services Prevention Act of 2018, states can use Title IV-E foster care funds to place children with their parents in a licensed residential family-based treatment facility. This slide here provides examples of family-based facility treatments, including some with substance use disorder programs in Minnesota, California, Utah, and Montana. As I'm sure you've heard, difficulty in obtaining childcare can be a strong predictor of reports of maternal neglect, more so than the severity of substance use disorder. In fact, mothers entering substance use treatment who report difficulty finding childcare are 82% more likely to self-report child neglect compared with mothers entering treatment who have access to childcare. The Administration of Children and Families Office of Child Care recommends that states include substance use treatment as an eligible activity for child care and development fund dollars, which states use to fund child care assistance in low-income families. Child care subsidies help enable or can enable low-income parents to work and help them meet their family's economic needs. For many parents with substance use disorders, affordable childcare is essential to completing outpatient treatment programs. Parents in or recently out of treatment facilities or programs can also benefit from home visiting. This is when a trained professional visits a pregnant woman or a new parent to provide support related to maternal health, child development, and support those parent-child bonds. The Parent-Child Assistance Program is a home visiting model that helps mothers with substance use disorder begin or maintain recovery. It helps to build the parent-child relationship and prevent prenatal exposure to substances. Washington is one of 5 states that's implemented this model. They fund the program through client fees and a dedicated marijuana tax revenue account. This can be found in Senate Bill 693. And Kansas included a parent-child assistance program in its 5-year Title IV-E prevention plan. In Kansas, this program is funded through the Children's Cabinet Community-Based Child Abuse Prevention Grant and the City of Topeka Special Alcohol and Drug Tax Fund. California, Nevada, and Oklahoma also use this model. This team has provided a number of resources for you as well that can really make this connection to child welfare and substance use, should you like to go into those or see any other questions in that space. And finally, I will just touch on maternal substance use and the carceral system. So according to data gathered by the Bureau of Justice Statistics in 2022, just under 93,000 females were incarcerated in local jails. It's important to note that between 2021 and 2022, the female population in jails increased by 9%, whereas the population for males increased by 3%. This does tend to represent a broad trend that we have observed over the last several years. During the past few decades, the number of incarcerated women has increased at twice the rate of their male counterparts. Many of these women are held in jails as opposed to prisons, and according to a 2024 data gathered by the Prison Policy Initiative, the majority of these individuals are awaiting trial and have not been convicted of a crime. Digging a little deeper into the data, it is estimated that over half the women in the US prisons are mothers, 80% of women housed in jail are mothers, and approximately 58,000 pregnant women are booked into jail each year. Recognizing the unique needs that pregnant women face in carceral settings, between 2019 and 2021, at least 14 states introduced and passed legislation pertaining to the treatment of pregnant women. These laws range from protocols around the use of shackles and solitary confinement to providing additional food and supplements to those who may be pregnant. And while there has been legislative momentum in the realm of improving conditions and rights of women in jail, policymakers and other stakeholders have also been exploring ways to reduce the reliance on carceral settings for individuals who have dependent children. So one particular legislative approach relates to community-based sentencing. Massachusetts, Minnesota, Oregon, Tennessee, and Washington are examples of states that have enacted legislation to expand the use of community-based sentencing as an alternative to incarceration for parents of dependent children who are convicted of a crime. It is important to note, however, that often statutory exclusions for this relate to violent crimes. Research has also shown that there is a strong relationship with a family and a child can help to decrease the rates of arrest for women into the future. Yet, for many women who do enter the justice system and are justice involved and are sentenced to a correctional facility, there are additional special considerations, especially when pregnant. For some context, a 2020 study found that 14% of the approximately 55,000 pregnant women jailed annually had a diagnosis of an opioid use disorder. We will note for this 14%, however, I think Dr. Wells also pointed this out, that this could be an underrepresentation. According to the authors of the study, states or jails who screened for this condition may not specifically have assessed this. And so this is really to say that it's unclear whether the diagnosis was derived from previously documented medical history, whether it's self-reported, or a combination of medical records and subjective history. So perhaps there are other women that did not disclose their substance use history upon entering a facility. So what is the standard of care for this particular population, and really how is it being applied in jails? In the healthcare community, there is a growing consensus, as I stated earlier, that treating a woman with opioid use disorder using MAT, which is medication assisted treatment, or MOUD, medication for opioid use disorder, is preferred to medically supervised withdrawal. And again, the American College of Obstetrics and Gynecology also recommends connecting this with behavioral health therapies and medical treatments as well. We also know that by looking at a few studies, that there are treatment models that are used in jails that do see some inconsistencies. So according to a study published this year, out of 836 jails surveyed across the nation, 60% provided medication for opioid use disorder if it was initiated prior to the pregnant individual entering the carceral setting. 32% of jails initiated medication-assisted treatment for pregnant women during confinement, and 23.8% of jails continued medication-assisted treatment postpartum. So in light of the data and the research that we're seeing states enact around addressing treatment for individuals, we also know that it's not just women or pregnant women who experience these needs within a carceral setting or in a county jail. There are a few examples here by this team about how states are working to integrate medication for opioid use disorder into jail settings. And then this slide here is going to just provide, again, a few resources from the Civil and Criminal Justice team, presentations, reports, and databases where you can find similar information. And with that, that really concludes just my overview of trends and legislation within the 3 policy areas. And I appreciate the opportunity to be here and to have Dr. Wells here. And we thank you and pass it back to you, Madam Chair.
Thank you so much. We really appreciate you, Tammy and Dr. Wells, presenting it to us today. We've got one more presenter. And so what I'm going to ask the committee to do, if y'all have specific questions, to look at their slides. And if you've got specific questions, and Tammy, I know I've already got some for you, that we get back to them. And Dr. Wells, thank you for that really detailed information that you put on that particular PowerPoint slide. That'll be of a great help to us. So thank y'all very much, and we appreciate y'all being with us. So thank you.
Thank you.
Thank you very much.
We have as our last presenter, and I know she's got to get out, so this is going to be a very quick presentation. We have Leah Smith, the Deputy Chief of Staff for the Lieutenant Governor, and we have been all working on the Youth Mental Health Task Force. And so Leah, if you will do a quick presentation on that, that'd be great. Thank you.
I'll be real quick. Good afternoon. I know you guys are all hungry and want to go to lunch or get back home or whatever you need to do, so I'll be real quick. I wanted to tell y'all, though, that Senator Boyd deserves special thanks on this task force because she authored this bill when it became apparent that post-pandemic, our children and adolescents were experiencing a significant decline in their mental health. And this isn't just in Mississippi, it's across the nation. And in my own work in the Lieutenant Governor's office, we have visited many, many schools. And I can tell you that teachers and educators everywhere really cite this as their #1 issue. In listening to all the testimony yesterday, and especially today with Wendy from the Department of Mental Health and others, I think they've covered a lot of what the task force ended up recommending. The task force was 24 members. It was not just legislators, but it was 4 senators, 4 representatives, educators, counselors, psychologists, agency representatives from Medicaid, health, mental health, public providers, private providers like Canopy, public providers like the CMHCs. Senator David Parker actually co-authored or co-chaired the task force. He was the proxy for Senator Dennis DeBar, and he served with Representative Rob Robertson, who's the chairman of education on the House side. Essentially, the task force was charged with identifying what we were already doing in the state, the significance of the problem, and then where the gaps were and the challenges and what we could do to address some of those things. So there were 21 recommendations. You can read over those on page 8, and I'll just kind of briefly go over them. The first one was updating the School Safety Act of 2019. And I know some folks were there when we passed that. That was really more aimed at immediate emergencies. And so we sort of recommended expanding that act a little bit to also address children in crisis. It may not be a school shooting, but it might be that they need help in some other area. So that included expanding that school safety grant program to include screeners, which is one thing that Wendy talked about, that really every child needs to be subject to a screener. Reestablishing those pilot programs that provided curriculum to help students manage stress and anxiety. Those started out in the pandemic in 2020, and then they were abruptly came to a halt when school came to a halt, but they were really showing promise. And I think Wendy would be better suited to discuss that, but they were showing some promise. We wanted to require, the task force wanted school districts and law enforcement agencies to work in closer proximity. So right now, on some school district campuses, law enforcement come and visit at least once a year and do sort of a threat assessment. And in other areas, they never walk on the school campus. So we wanted them to enter into MOUs and just be present on the school campus and know what it looks like just one time a year. Expanding the MCOPS program. That's the program that provides $10,000 for each officer in state funds and a 50-50 match with the district. And it can be, that person can be employed by law enforcement or by the school district. I cannot remember how many we have right now, but it is woefully under what we need. Even if you consider that an SRO often floats from one school to the next, you don't need one for every single school. But even considering that, we're way under where we need. And then the last one is something that Senator Boyd actually worked on in 2021. And it didn't pass, but maybe it'll get some attention this year with Wendy and with our office. But that was to include, require every school to have a crisis team of sorts, a trauma-informed team, whatever you want to call it, that is sort of key personnel in the district that can identify when a child's in crisis and then get them to the right resources. So they're not responsible for providing the resource, the teacher isn't, because they're not equipped to do that, but getting them to whatever they need. The second recommendation really just relates to standardizing law enforcement training for SROs. Right now, they're only required to have very basic training within 2 years of becoming an SRO. So, you know, that might get some pushback, but it's important that they actually have SRO training that includes community policing, the mentoring aspect, which is really important in an SRO. The third one is something that I think Senator England was maybe interested in, related to finding out what the real problem is and then figuring out what to do about it. One thing this committee discussed at length is a book called The Anxious Generation by Jonathan Haidt. And if you haven't read it, it's very interesting, related to the mental health of children. And one of the things it talks about is how children's brains have been rewired during this epidemic of smartphones and smartwatches and social media. And so one of the things the committee is recommending is prohibiting the use of social media, smartphones, smartwatches, all of that, at least during an instructional time. The book recommends bell to bell. It recommends complete elimination, which is hard to do. But when that happens, children start interacting face to face. There are less disciplinary issues. It's very clear that there's data correlated to depression, anxiety, suicide, all of these things related to just smartphones. So that's one thing that it may be easy to do, an easy answer. Another thing that the book recommends is prohibiting canceling recess time for K-5 kids as punishment. Kids need recess when they're that little. It's part of their mental health and development. And while we do have mandated recess time here, we don't prohibit it as a form of punishment. I'm not aware of any district that's actually doing that, and I'm not saying that they are, but that is one thing that the book recommends, and that's the fourth recommendation here. The fifth recommendation is requiring an evaluation of mental health support and services in a school district when a school is taken over by the state. So that would just be an additional criteria that the Department of Education would work with the Department of Health and whomever else on to make sure that those children are getting the services they need. The sixth is requiring mental health first aid training for all teachers and administrators. I think Wendy talked a lot about that, so I won't harp on it. It's not expensive though, and right now it's being covered by a grant. The seventh is requiring the Department of Mental Health to review and update school district policies and curriculum on suicide prevention. we found that we sort of implemented that law and then we never looked at it again. And I mean, I think our stats have really not gotten a lot better, and I defer to Wendy on that again, but I think we really, the task force felt that we needed to not only implement training, but then go back and look at it and make sure that it was up to date. 8 and 9 is about assemblies. The task force felt it was important to gather students together at critical moments in their high school and post-secondary career and tell them what was available to them, and then also tell them policies that might be relevant, like cyberbullying, technology policies, whatever it might be. And for the Department of Mental Health to help coordinate on what materials would be handed out in that. Number 10 is related to screeners again. One of the screeners that we talked about was sort of a paper screener that the DeSoto County schools were using. Another screener that we talked about was the Canopy Anywhere app, which is based on hope science. So it's how hopeful a child is, and that might indicate where they're struggling. Number 11 is about schools, community colleges, and universities partnering with our CMHCs, which I think Wendy talked about. Everyone's not partnering with all of the resources in their communities. They're just not talking to one another. The 12th is about peer-to-peer programs. So particularly, we had a high school student serving on the committee, and he talked about how it was really important to implement these peer-to-peer programs because children are more likely to tell another child or a friend or whatever that something's going on with them, and then that friend can get it to the right adult. And I did just want to put in a really quick plug for the Hope Squad program, which is going on down in Jackson County, and Senator England has more information about that, but my friend Paige Roberts, and probably a friend of all of yours, kind of has helped spearhead that, and there's an event on October 27th with the national CEO, and I think Senator England has sent information about that. Number 13 is requiring the Department of Mental Health in collaboration with MD to submit a report that inventories all of the resources that we currently have available, because it seems like we have a lot of things going on and we don't know exactly what all those things are. And we need just sort of a one report that tells us what's going on to eliminate duplication and be more efficient and all of those things. Number 14 is about an internet-based mental health resource guide, which I think the Department of Mental Health has already started and is adding to. The task force felt like it was important to have a button on every school district website that linked to that. Number 15 is requiring school IDs to include the 988 suicide and crisis hotline number. This would not be requiring every school to print school IDs. Just in the next round of printing school IDs, if they had school IDs, they would need to put that 988 number on it. Number 16 is encouraging schools, community colleges, and universities to designate space within existing structures for confidential therapy and counseling. It's become apparent that maybe they're using the conference room and it has the one copier in it, and then the teachers all have to go in that room to get copies, and then the therapy has to stop, and it's just not helpful. So not building new space, but taking that into account in current space and then in new construction. Number 17 is adding school psychologists to the list of professionals that receive that $6,000 supplement. Right now, counselors do receive that, but school psychologists do not. Number 18 is creating a loan repayment program to encourage a broader workforce of psychologists and other folks that are in that realm, kind of similar to the Winter Read program that we did for teachers not too long ago. Number 19 is researching the efficacy of other targeted actions like tax credits, waivers, and increasing reimbursement rates. I know y'all talked about that earlier today. The committee didn't dive into that too much, but just talked a little bit about how that impacts all of this. Number 20 is about requiring MD to create staggered goals to start moving toward the 1 to 250 students ratio for counselors. Right now, Mississippi is at about 1 to 450. So we're kind of double where we need to be. And then number 21 is extending the repeal date on the task force. So that report came out on Tuesday, so it's hot off the press. And do y'all have any questions?
Do y'all have any questions? Senator Wiggins?
I'm sorry, I'm trying to think of a cross-examine question here. No. So with, this question is something that's been, that I struggle with, and having been on the education committee. And then we heard earlier when I had asked Wendy Bailey to be a czar, and she said, do assessments in school. And then looking at this, we're talking about, say, schools needs to do sexual abuse, for sexual abuse. We need to add psychologists. We need to prohibit cell phones. We need to, do everything like that. And then Senator England talked about when we go and meet with the superintendents and all, generally what we end up talking about is not education related. It's all these other things. And when I go and talk to teachers, what I hear a lot is, I just want to teach. And we, meaning this body and then we mandate all these other things beyond teaching. And with your background in education and what you do, I mean, I don't know. I don't have an answer, but I'm asking for your comments because I think it's a real issue that our schools, they're going beyond just educating. And I know our teachers are struggling with that. And we're trying to treat the issues like Senator England was saying, but it's about education when you drilled. That's what schools are for, but we're doing everything else. Thank you, Senator Hill. We're doing so, and I'm not criticizing the recommendations because I know that's it, but just in this one thing, there's at least 4 or 5 recommendations to do things beyond just about education. And so I'm open to hear that.
So I'm not a member, I was not a member of the task force, just a staffer that prepared the report and helped with research. But I would say that one of the things the task force.
Yeah, but hold on, you've been education policy, you've been all of that, and now you're going to be Miss Healthcare Policy. So what do we know?
Well, one thing I would say about the report is I think they did try and address issues related to teachers doing more than they're required to do with things like the crisis teams. So for example, Senator Boyd, with her trauma-informed team, the whole point of that was to get the teacher away from providing the service, identify the kid, and then connect them to an outside resource, whatever that is. If it's the counselor, if it's the CMHC, we have school districts in the state that don't even know who their CMHC is. And so I think it is more about connecting the student with the resource outside of the classroom. Same thing with the cell phones. I think teachers will tell you they are tired. They're tired of looking out into the class and seeing everyone under a desk looking at a smartphone, and they can't teach that way. And they don't have any cover to take them away. So I think the recommendations were aimed at separating those two, but then making sure that everyone's talking.
But I'm asking you to go beyond that. How do we get past, or how do we address this issue that schools are about? It's about education, teaching, and then we're passing laws, we're considering things that are mandating things that have nothing to do with the actual part of education.
I think it's a big challenge for teachers, and I think we've got to get out of their way and let them teach.
I think Senator Wiggins too, being on the task force too, everyone was very cognizant of that. The policies that we recommended in here are actually to help the teachers actually be able to teach and get the things that need to be dealt with by other professionals out of the classroom.
And
that was kind of the whole, that there were many conversations and side conversation and sidebars to this. The other thing too is that we still have to be very cognizant of, you have a child that comes into a classroom with extreme mental health issues. Those issues are going to affect the entire classroom. Just like as a mother of a special ed child, I knew that if my child walked into that classroom without the appropriate supports that they needed to support him, that then it was going to impede other children's education. So this is the world that we live in. Our youth court judges responded yesterday that it is a different world. We are not talking about completely different things and issues than we were in the 1950s and the 1970s. And so we have to adjust appropriately. And this task force tried to do a very good job. There were lots of ideas, but they succinctly tried to look at things that were going to help make sure that we put the appropriate professionals to deal with those issues so that our teachers can teach. And that's kind of the whole point of this.
Yeah, it seems to me like that should be an approach that we do because, yeah, teachers need to teach in the school. The mission of the school is to teach understanding all of this, but the teachers and even the administrators shouldn't be diagnosing sexual abuse and diagnosing that. I understand.
That's why we have legislation and the crisis teams and all of that, because of just what you said. So these are things and supports to help school district. But I'm also going to say this too, as having the daughter of a school administrator for a number of years, even back in the 1970s, my father was having to help children with issues that went way beyond X's and O's and 2 + 2. That is the nature of our administrators, and it always has been. They're never going to deal with strictly just educational issues, because how that child walks into a classroom every day is what it is. So I can remember, this is years ago before cell phones and all of that, but answering the telephones until late at night at my home, helping families deal with different issues and the children that deal with them. And that's why we love our administrators and we love our teachers, but it is just more than just purely academics.
And my mom, as a 30-year teacher and a librarian and all that, I understand that. You said it, we're cognizant of this. And it is more than, I understand more than just that, but we just have to be smart about it.
We do.
Senator Wiggins, I would say that during the pandemic, after that ended and kids were back in school, one of the things that teachers said to me was I wasn't able to lay eyes on my kids. And that was really hard. And I think it's good for teachers to lay eyes on their kids every day because they can see changes in them that might trigger something. I think what's inappropriate is to make them be the provider. And I think what the task force really identified was we have real gaps in people just knowing what's available in their communities. I mean, to not even know a private provider in your community or your CMHC that you could refer someone to, that's a big lapse. And it just means that when the teacher lays eyes on that child, then they're having to deal with it. And, you know, I think the conversations are ongoing about the things that we put on teachers and law enforcement and people that aren't trained or have the capacity to do the things that mental health care providers do.
Senator England.
Yeah, and I'll be real quick. Leah and Task Force, this is a great report. I think that the way that the recommendations are lined out is very helpful. I think that other committees that are doing this could look at this report and see maybe how to outline these in a very concise way that we can look at. Of course, we all know there's things that we can't legislate away in this building. And so every time I have a platform to say it, I want to say that we had several teen suicides in Jackson County over the last couple of years. It's very sad. We've had it in Oktibbeha County, we know from speaking with Senator Williams. We've had it in other places, and that's just heart-wrenching. I mean, that's the scariest thing for a parent. And every time it's happened, social media has been involved, okay? And smartphones have been involved. And so I just want to say to anyone listening while we have this platform here that children do not need to be on social media even up to the age of 18. I know that's tough, but we have to understand that. And smartphones don't belong in the bedrooms after 8 p.m. And that's something else that kids just do not need access to some of the stuff that's online right now. And I know that's tough, and I'm not telling people how to parent. I'm just telling you that every instance of teen suicide that we've seen, that's been a big issue. And every parent that has had to come talk to us or talk to me it says one thing, it says the two things. I wish I would have been tough and I would have said, I'm sorry, everybody else is doing it, but you don't get social media. And number two, your phone is hooked up either in your parents' bedroom or downstairs. When you go to bed, you're not going to have it. It's going to be tough. I've got one at home right now that's unrestricted from her iPad because her grades weren't so great this last semester, and she's pissed. But we just got to do it, you know. So I think that's very important. Again, can't legislate that. Another point I wanted to make, and this isn't for today, and it's something that I think that we need to look at, though. When we talked with our superintendents, another issue they had were when students were picked up, just about safety in schools, when students were picked up on a weekend in possession of a firearm, and they had committed a crime and they were in possession of a firearm, but they still had to have their time in court. They're in school on Monday mornings a lot of times, and word gets out. So these schools are having to deal with either parents not sending their kids to school because they know a child's going to be there that was picked up for a gun crime or a crime with a gun being in their possession, and they have a problem with those students just basically smiling in their face and knowing they can't do anything about it, and they can't. And I know there's a lot of constitutional issues we have to be wary of there, but that's one issue that y'all may have talked about in the task force, and I'd love to hear more about it. I know that's not a question to be answered right now while everybody's ready to get out of here. Thank you all very much, though.
Senator Bryan, I think you had the next question, or did you have a comment? Okay. All right, Senator Hill.
Just very quickly, I have 3 school teachers who are close friends of my daughter's that went to school with her. I actually taught one of them. What I hear from those 3 girls, and one just left, was a cheerleader sponsor, very involved, love the kids. But what I hear from these 3 girls, one is now the wife of an NFL quarterback, is that when I was teaching in a Mississippi school, and 2 of them were A schools, that Miss Angie, I don't know what these kids are going to do when they grow up because they're not being taught. We can't teach them. The curriculum's not what it should be, and we can't control the classrooms, and it gets worse every year, is what I'm hearing from these teachers. And they love kids. They want to stay there. So what I would like to see is a teacher's bill of rights, because these teachers don't deserve to be called the F word and the B word and all these things that they're having to put up with in the classroom. And, you know, they're not doing it for the money. Yes, we've given them decent raises, more than what has been in the past. But when I know people that really, truly want to do the job, like I wanted to do the job, but people were breathing down my neck to make me become a failure as a teacher. And I said no, and I walked out. And these girls are walking out, and they're good role models. They know what they're doing. They do extracurricular activities. One's a graduate of Millsaps. One's a graduate of, 2 are graduates of USM, who has used to have a very good teacher prep program. I think if we don't see a teacher bill of rights, they're not being supported by the administration. They're not being able to hold the kids accountable. And when I see kids in A high schools that are smart kids that are not making above 13 or 14 on their ACT in an A school, and I know these kids and I know they're not dumb, we got problems, and we need to admit that. And I think if we get that classroom straightened out and give that teacher back that control and allow them to give grades that the kids are actually making, like when we went to school, you'll see a big change.
Okay. Yeah.
That is education. That's not changing the subject.
No. I'm going to close this out because we have gone one. Yes. Did you have one comment? Okay. We've gone, I want to thank the committee. We have gone almost an hour past when I told you that I would have you out. You sat through a long 2 days almost hearings on this. And so I'm greatly appreciative of you. We will be convening back on the 15th with the joint meeting with 14th. Is it? Or 14, okay. Of November, we will have a joint meeting with the Labor Force Participation Committee, and we will be looking at all the labor force issues for women, children, and families. So, and we've got a full hearing. It will be that afternoon. It starts at 1 and we'll go to the afternoon. And then we come back on the 18th and 19th, and that Monday and Tuesday. So thank y'all very much. And we're going to conclude. Thank you.